What's up, guys? Jeff from Sorta Healthy here. Today we have one goal: pass the ACSM EP or Exercise Physiologist exam. This test is no joke, and many people struggle to pass it even after completing a degree in exercise science or something similar. If you make it through everything I'm about to lay out for you, though, not only will you not struggle on testing day, I'm confident that you'll easily pass this on your first try. I've helped thousands, probably tens of thousands of trainers to pass different certification exams, and you will be no different. You know those concepts that seem super complicated in the book? I'm going to make them so easy and simple that you'll have no choice but to understand them. So are you ready to pass this ACSM exam and begin the next chapter of your life as an exercise physiologist? Of course you are. Why else would you be here? Throughout today's video, I'll be referencing a study guide. This guide is free to download at the link located below in the video description. If you'd rather just follow this video along and not download the guide, that works perfectly well too. All I ask in exchange for all this free stuff is that you like this video and subscribe to the channel if you haven't done so already. Both of those things really do help us out over here at Sorta Healthy, and this channel is a free resource for all fitness professionals. Thank you so much for that support, everyone. It really does help. On to the rest of the video. Moving on to steps to passing your ACSM Exercise Physiologist exam. Now, is this book, ACSM's Resources for the Exercise Physiologist, the 3rd edition, necessary for passing? I don't know that it's essential, but it's definitely good to have. ACSM's courses are embarrassingly bad, so unless you're just finishing up a 4-year degree in exercise science or something similar, yeah, I think you'll probably struggle without reviewing this. Either way, skimming this book can definitely be helpful, and I'll leave the best deal that I could find on it down below in the video description. So step 1 is to skim this textbook. Yes, all of it. There is quite a bit of book learning in this course. Now, when I say skim the textbook, I do mean it. You don't have to read every single little detail, and while skimming the book, you should be taking light notes along the way. Step 2 is to review this part 1, the video you're watching right now, and the upcoming part 2 video a few times each. The part 2 video should be out in a week or two if you're watching this one right after it's uploaded. Anyways, the part 1 video, the one you're watching right now, covers the most important concepts that are most likely to appear on the final exam. The part 2 video is going to be a bunch of trivia questions and answers where I'll be showing you how to apply the information. Step 3 is to review on the Fitness Pocket Prep application. Pocket Prep is inexpensive, it's super convenient, and it's just a fantastic way to make sure that you know the material well enough to pass. Pocket Prep is especially great for people who struggle with weirdly worded questions. Link for Pocket Prep down below, and I'll talk more about how to use it in the next video. Step 4 is to consider a practice exam. ACSM has one, and we have one too. Obviously, I'm biased, but I think ours is a much better deal. I bought theirs, and yeah, I wasn't impressed. Ours is only going to be $20 upon release. It probably will go up over time. It will have 60 trivia questions where I will personally be walking you through why some answers are correct and others are wrong, and I think that will be really helpful for learning the material. I do want to make it clear that you don't necessarily need to do step 3 and 4 here. They're both inexpensive and will increase your chances of passing. Just remember that retaking these exams is a pain in the butt and it's kind of expensive, so I would recommend taking your studying as seriously as possible. Basically, do everything you can to pass the first time. And on that note, we're going to kick things off with some very basic anatomy. You're likely to get a few questions on very basic anatomy, but nothing too crazy. So anyway, there's 206 bones in the human body. The axial skeleton has 80 bones, and that is the core of the body, and that includes the skull, the ears, the neck, the back, and the ribcage. You also have the appendicular skeleton, and that has 126 bones, and that's the limbs or the appendages. So within your body you have osteoblasts, and these are cells that build or repair bone. The opposite of that is an osteoclast, and those destroy bone. What is the longest bone in the body? That is the femur, or this upper leg bone that you can kind of see in this picture over here. The patella or kneecap is a sesamoid bone, which you can see the patella or kneecap right here. So there are 4 main types of bones: long bones, short bones, flat bones, and irregular bones. Sesamoid bones, like the kneecap we just described, would often be kind of lumped into irregular bones. So the human movement system, or kinetic chain, is made up of the skeletal system, the muscular system, and the nervous system. So the skeletal system provides support and protects organs. It's the body's foundation. It makes blood for the body, and it stores necessary minerals. The muscular system links the nervous and skeletal systems together. It allows for movement, and there are 3 different types of muscle. You have skeletal muscle. Skeletal muscle is muscle that you have direct control over. So if I'm doing this motion right here, my biceps are doing that motion. My biceps would be skeletal muscle. Smooth muscle would be things internal. For example, you have smooth muscle in your stomach and other organs, and cardiac muscle is in the heart. And again, skeletal muscle is the one that we have direct control over. The other 2, not so much. So synovial joints are the most common in the body, and there are a few different types of synovial joints. So your radius and ulna, these 2 arm bones right here, they form a pivot joint because they kind of pivot around like that. Now your knee, or actually your elbow here too, those are hinge joints because they kind of just hinge forwards and backwards in one direction. Condyloid joints, don't really have to worry too much about those, but you have some in your hand and your fingers, for example. Saddle and plane joints, don't really need to know too much about those. Ball and socket joints, well, you have one right here in your shoulder, also your hip, and they allow for a whole bunch of different ranges of motion. Moving on to the central and peripheral nervous system. The central nervous system consists of the brain and spinal cord. It's responsible for receiving, processing, and responding to sensory information. The peripheral nervous system is made up of nerves that extend from the spine to all other parts of the body, and they send info back to the CNS, or the central nervous system. Some good vocab to go over real quick here. Definitely could pop up on the test. A neuron is a basic unit of the nervous system. A neuron has an axon, a cell body, and dendrites, and it allows you to do everything from breathing to running, pretty much anything. A sarcomere is the basic contractile unit of a muscle fiber, good to know, and a motor unit is made up of a motor neuron and the muscle fibers it innervates. So motor function is the brain's ability to perform purposeful movement. It includes voluntary and involuntary contractions. We have the all or nothing principle, and that is when a nerve or muscle cell will fire 100% or not at all. Muscle cells are going to either go full force, 100%, or they're not going to contract at all. Heavier resistance stimulates, should say more muscle fibers to fire. So if I'm bench pressing 200 pounds, basically all of the muscle fibers that are firing, they are firing 100%. But more muscle fibers are going to fire if I'm bench pressing 200 pounds versus 100 pounds. Just more muscle fibers activating. They all activate 100% or not at all. That is the all or nothing principle. So there's 3 layers that surround muscle tissue. The epimysium is the outermost layer. Then you have the perimysium, and that's the middle layer, and that's the sheath of connective tissue that surrounds a bundle of muscle fibers. Then you have the innermost layer, the endomysium, and that surrounds individual muscle fibers within skeletal muscles. Also good to know that ligaments, like your ACL for instance, attach bone to bone, and that tendons attach muscle to bone. Probably gonna get a question about that. And guys, if you feel like your knowledge base is a little bit lacking when it comes to basic anatomy, I do have 3 videos to help out with that. I have one that goes over basic bone anatomy, one that goes over basic upper body muscle anatomy, and the same thing for lower body muscle anatomy. Consider watching all of these once or twice before taking that big test. For example, if I were to hit you with a question like this, which of the below muscles extend the knee? A. Vastus lateralis, B. Biceps femoris, C. Rectus femoris, or D. A and C. You should be able to quickly figure out that D is the best answer to that question. You should note the quadricep muscles are the ones that extend the knee, so all the vastus muscles and the rectus femoris. You should also know that biceps femoris or femoris is a hamstring muscle, and the hamstrings do knee flexion, not extension. Again, the quads do extension. If any of that was confusing, you really should review these videos a few times and make sure you know the basic muscles and their actions. Don't go too crazy, just focus in on the big muscles and what they do. By the way, if terms like flexion and extension are foreign to you, keep watching because I'm going to teach you all of that stuff soon. But before that, onto some nervous system info. You have the sympathetic nervous system, which is part of the autonomic nervous system, meaning it kind of just kicks on whether we want it to or not. And the sympathetic nervous system is pretty much all about the fight or flight response. You can see this dude over here, he's ready to fight. You might also be ready to run away from something dangerous too. Fight or flight, sympathetic nervous system. The parasympathetic nervous system is also part of the autonomic nervous system, meaning it just kind of kicks on automatically, automatically. And that one's all about resting and digesting. So these two are kind of opposite to one another. Parasympathetic, rest and digest. The somatic nervous system allows you to control your body's movements and receive external stimuli. So unlike the sympathetic and parasympathetic, you do have control over your somatic. So the sliding filament theory is basically just the theory of how muscles contract. So the sliding filament theory is when actin and myosin is larger by the way, slide past each other to generate movement. So myosin, again the larger of the two, and actin sliding past each other and kind of ratcheting to one another. Again, it kind of works like microscopic Velcro, and that is what's happening inside of your muscles to generate movement. This does occur in the sarcomere, which we just said is the basic muscle unit. Speaking of muscle fibers, you have type 1 muscle fibers and type 2 muscle fibers. Type 1 muscle fibers are slow twitch. They are more important for endurance events. They're lighter and less powerful, and they're mostly aerobic, and that means oftentimes fat and just food in general, that's going to be fuel for these muscles. Then you have type 2 muscle fibers. They're fast twitch, they're larger and paler than type 1. They're anaerobic, meaning they don't require oxygen, and they're really used for short, explosive periods of physical activity, so sprints, heavy lifts, things like that, and they use carbs, glucose, things like that as fuel. So arteries carry oxygen-rich blood away from the heart to the rest of the body. I repeat, arteries carry oxygen-rich blood away from the heart to the rest of the body. Veins carry deoxygenated blood from the body to the heart, where it goes to the lungs to be reoxygenated. So veins are carrying deoxygenated blood, no oxygen in the veins. Capillaries are the smallest blood vessels and the site of exchange for nutrients, oxygen, CO2, things like that, and they provide nutrients to the tissues. Moving on to some basic heart stuff, you have 4 different heart chambers, 2 on the top, 2 on the bottom. Right atrium and left atrium are on the top, and your right ventricle and left ventricle are on the bottom. The atria are smaller and they kind of serve as blood reservoirs, and the ventricles on the bottom are bigger. So we're going to go into some of this stuff in more detail in a second, but the right atria receives deoxygenated blood from the body. The left ventricle pumps oxygen-rich blood to the body through the aorta, and the SA node, the sinoatrial node, is the pacemaker of the heart. Next up, we're going to talk about blood flow through the heart. I'm going to keep things as simple as possible, and in all likelihood you'll get 1 or 2 questions about this on the test. Okay, so I've broken down blood flow through the heart into 5 different steps. In step 1, oxygen poor blood, or blood that doesn't have any oxygen in it, enters the right atrium, and the right atrium is this part of the heart right here. So in step 2, the blood flows through the right ventricle, and the right ventricle is right beneath the right atrium. In step 3, blood is pumped to the lungs from the right ventricle, so the right ventricle is sending blood to the lungs to get reoxygenated. In step 4, the oxygenated blood returns to the heart, and then in step 5, that oxygenated blood goes from the left atrium to the left ventricle. You can see the left atrium, left ventricle over here, and the left ventricle pumps the blood that now has oxygen inside of it to the entire body. Important to know that last bit, the left ventricle is pumping the blood with oxygen inside of it to the entire body. I wouldn't say all of this is worth memorizing. It is worth looking over a few times because, like I said before, you are likely to get a question or 2 about this on that final test. Moving on to exercise guidelines. So health-related fitness is comprised of cardiorespiratory fitness, muscular endurance, strength, flexibility, and body composition. Good one for you to listen to me say a few times, but definitely not necessary to memorize. This one is worth memorizing. Recommendations for cardio: moderate intensity, 30 to 60 minutes, 3+ days a week, or 150 to 300 total weekly minutes. Make sure you know that. For some healthy people, vigorous intensity might be the preferred method. And when it comes to vigorous intensity, 20 to 60 minutes, 3+ days a week, 75 to 150 total weekly minutes. And you actually can kind of mix and match here a little bit too. It's not like you have to strictly do one or the other, but these are the minimum guidelines if this is your thing. And again, memorize both of these pieces of information. And like I just said, you can do some moderate and some vigorous. You don't have to strictly do one or the other. Weight loss clients are going to want to be on the higher end of that range we just talked about, so 50 to 60 minutes daily, 250 to 300 minutes weekly. More advanced clients may be higher up on those ranges, and I feel like that one's pretty self-explanatory. And this is going to be true for beginners especially, but if you have to break up cardio, try for multiple 10-minute 10-minute bouts. Again, if someone's really deconditioned, they might not be able to exercise for that long, so they might just have to do 10 minutes at a time and do a few of those bouts throughout the day. Those guidelines we just talked about don't necessarily apply to kids too much. Kids should just do 60 minutes of activity a day. And this is only on a somewhat related note, but in terms of resistance training, kids should start at age 7 to 8. Still good to know. We just talked about this before, but if you're working with someone new who is deconditioned or very new to exercise, you might advise that person on week 1 to do 10 minutes twice a day and try to get 60 minutes weekly. And then each week, 15 minutes should be added until 120 minutes weekly is reached. And then after that, you're going to want to increase the intensity for a couple of weeks. And then once they're used to that, add 15 minutes per week again. Keep going until 200 minutes per week is achieved. I wouldn't bother memorizing any of this one, but of course, something from this slide could come up on the test. So now we're talking about some session components, and of course, a session is made up of a warm-up, you have conditioning, you have a cool down, and you have some stretching at the end. The warm-up should be at least 5 to 10 minutes of low to moderate intensity cardio, and you should have some muscular endurance activity in there as well. Conditioning would be 20 to 60 minutes of aerobic, resistance training, etc. You can build up from 10 minutes if needed, like we said before. And the cool down is pretty much exactly the same as the warm-up I just mentioned, at least 5 to 10 minutes of low to moderate intensity cardio and muscular endurance activity. After all of that, the client is going to want to do some stretching, and typically static stretching, which is basically like where you're just kind of holding a stretch for a little while. And you're going to want to do that for at least 10 minutes after the warm-up or the cool down. Again, in the warm-up, it might be more dynamic stretching, and if we're talking about at the end of the session, it's going to be more static stretching. Children and adolescents, so we're talking people from the age of 6 to 17, they should be doing 60 minutes a day of activity. That should include moderate and vigorous intensity things. They should be doing at least 3 days a week of vigorous stuff in particular. Muscle and bone strengthening should also be included 3 days a week, and that, of course, could be weight training. It's not limited to just weight training, kind of jumping around, weight-bearing activities. Yeah, that would all count here. Moving on to older adults, similar guidelines to adults. In a lot of cases, they're exactly the same. Balance training should be included. If they can't do 150 minutes weekly, that would be of moderate intensity exercise. They should do as much as they can. They can also kind of build up in 10-minute increments throughout the day and just keep building up over time until they can get to this threshold here. Moving on to resistance training guidelines, we have frequency 2+, so at least 2 non-consecutive days a week. And these are just general guidelines. We're going to get more in depth with these things pretty soon. The intensity for untrained people, 60 to 70% 1 rep max for 8 to 12 reps. That's just generally what you're looking at. You probably should memorize that one right there. Trained people, they can actually exceed 80% 1 rep max, and that's if they're looking for strength. It'd only be 1 to 6 reps in that case if they're that high intensity. There's other rep ranges that can be used depending on their goals. If they're not focused on strength, if they're focused more on muscular endurance, we'll talk about that more soon. Volume, untrained may only need 1 set per muscle group. If someone is really untrained, it's not going to take a whole lot of stimulus for them to get stronger and improve. Type, we got multi and single joint exercises that target agonist and antagonist muscle groups. And if you don't know what that means, keep watching. Well, you definitely should know what that means. But we're going to break it down throughout the course of this video, and you'll understand it very well soon. Pregnant and postpartum women, they should be doing at least 150 minutes of moderate intensity exercise weekly. They should see a doctor before starting exercise, and those who did vigorous exercise before pregnancy can continue through pregnancy. There are a few things they should avoid. We will talk about that later. But yes, if they were doing intense exercise before, they should continue doing that in pregnancy. Exercise participation. To not be sedentary, you need at least 30 minutes a day, 3 days a week for 3+ months. You need at least this much exercise over the course of 3+ months to not be considered sedentary. We will be talking more about that soon. Then we have light intensity exercise, moderate intensity exercise, and vigorous intensity exercise. There's different ways of figuring out which type of exercise you're doing. So 30 to 39% heart rate reserve, VO2R, VO2 reserve, that's going to put you in light intensity, 40 to 59% moderate, 60+% vigorous, and we have RPEs, we have METs. We're going to talk about all of these things quite a bit more. We also kind of have some breakdowns here. This is just good to look over a few times. This information is going to come up on that big test in really a few different forms. Make sure you look this one over at least a few times. Next up, we're going to talk about FITTVP, and there are 6 variables that influence training. You have frequency, intensity, time, type, volume, and progression, and it's important that you know what all of these things are. So some general FITTVP guidelines for resistance training: at least 2 to 3 days a week for major muscle groups. 48 hours between workouts is good or ideal. And things, should be an S here, will vary a lot person to person, scenario to scenario. When you're increasing the difficulty of someone's program, one of the first things you'll do, maybe the first thing, is just add time. So if they can only work out for 10 minutes, again, you're going to add more time as you go forward. Duration would be similar to that. Intensity and volume, all of these things would increase over time. Also, of course, program balance is essential. You wouldn't only do upper body days or only lower body days in most scenarios unless a client has very specialized goals. Again, program balance is an important thing to have. Speaking of balance, let's talk a little bit about balance and neuromuscular training and the frequency, intensity, time, type, volume, and progression there. So for certain populations, you're going to want at least 2 to 3 days a week and 20 to 30 minutes duration. So in terms of frequency here, 2 to 3 days a week. In terms of time, 20 to 30 minutes duration. Type would be balance or neuromuscular training. Volume would essentially be 2 to 3 days a week, and again, the 20 to 30 minutes duration. When it comes to sets and reps, ACSM isn't super clear on what exactly you should be doing for balance and neuromuscular training. And as far as progression goes, things that you can do to change the difficulty level over time: you can narrow the base of support, you can change the center of mass, and you can use peripheral cues to get more challenging. Some examples of balance exercises that ACSM recommends are standing on one leg or standing on a balance pad. Of course, many more examples do exist. Instability training progressions. Basically, as you are working with a client to improve their balance or stability, you would progress things over time as they're making progress. You'd start things off with a wide staggered stance, and they would be standing on the floor with their eyes open. Next up, wide staggered stance on the floor, eyes closed. Wide staggered stance, feet on the floor, eyes closed, and their weight would be shifted. And then we could go on, so on and so forth. We have some narrow staggered stances. We have single leg stances, and it gets progressively harder. It's definitely not important to memorize all of this, but it is a good one to look over a few times, because understanding this progression, well, yeah, that is definitely something that could pop up on the test. Moving on to flexibility training, we just have some guidelines here. So you want your client to do flexibility training at least 2 to 3 days a week. Daily is most effective. We're doing 10 to 30 second stretches. We're doing 2 to 4 sets of those static stretches for most. And that's really where you're just kind of like holding a stretch. I don't really know if you can see me all that well, but I'm stretching out my tricep and shoulder there. I'm just holding that stretch for 10 to 30 seconds. I would do 2 to 4 sets of that. Older people, they want to do 30 to 60 seconds, and I've seen that pop up on tests, practice tests, so make sure you know it. PNF stretches. This is a 3 to 6 second contraction, and it's a 20 to 75% contraction, followed by 10 to 30 second assisted stretch, and oftentimes this is done with a partner. So you'd be stretching out someone's hamstring, they'd push that leg into you, and then you could stretch their hamstring a little bit further. Obviously, there's other examples, but that's the one most people think of. All types of stretching, dynamic, ballistic, static, PNF, they can be effective. Ballistic is sometimes frowned upon. It's going to come up in this video later. It can be a little more explosive, a little more crazy. Dynamic is typically what you're doing before a workout. Static is we're just holding a stretch. PNF is oftentimes done with a partner, but you could like use a band and kind of almost do it with yourself. Anyways, know what these things are and good to know these guidelines too. So some guidelines for obese or overweight people: aerobic training 5+ days a week, resistance training 2 to 3 days a week, flexibility you want at least 2 to 3 days a week. And we have some intensity numbers here, and oftentimes you'll have to start off at a lower intensity and then you can progress to a higher intensity later. You could see numbers for that here. We've already gone over that a little bit. Time 150 minutes a week and increase to 250 to even 300 minutes per week. We have some intensities here: 60 to 70% 1 rep max for resistance training. Of course, this could vary, but these are just general guidelines that are good to know. 2 to 4 sets, 8 to 12 reps, pretty similar to what other groups are going for. Which exercise should you avoid with a client who is morbidly obese? Walking, seated chest press machine, modified hurdler stretch, or D, a biceps curl with dumbbells. Think about it, it's pretty obvious, but this would be one that you really wouldn't want to get wrong on the actual test. So let's make sure you get it correct. With someone who is obese, typically you would want to avoid the modified hurdler stretch, and you can see it right here. A lot of you probably didn't know necessarily what it was, but you are seated on the ground, and with someone who's really big, honestly, just getting up and down off the ground can be a real challenge. So that is already one thing that may not work out so well there. It can put pressure on certain joints too. Whereas walking, yeah, if you're careful, that's really good for helping to lose weight, not going to put as much pressure on the joints. This one, you're seated, bicep curls. Obviously, you could do that seated. You could do it standing. So yeah, modified hurdler stretch. Be aware, not so good for someone who is morbidly obese. Pops up on the test probably more than it should. Back to older adults, and if something keeps popping up in this video, which, you know, that's going to happen with quite a few subjects, that means it's more likely to appear on the exam. Older adult questions are pretty common. So aerobic training 5+ days a week, resistance training 2 to 3 days a week, typically non-consecutive days. So it'd be like a Monday, Wednesday, Friday kind of a deal that we have some time in between for recovery. Flexibility at least 2 to 3 days a week. Beginners, 1 set, 10 to 15 reps at 40 to 50% 1 rep max. Move to 60 to 80% over time. Not necessarily essential to memorize these numbers exactly. Really not the case for any of these resistance training things, but you're going to get multiple choice questions about them, so you just have to generally know them, and then you're going to know them well enough to get it right on the test. 8 to 12 reps at moderate, which would be an RPE of 5 to 6. To vigorous intensity, RPE 7 to 8. Power training, which is more explosive and high velocity, is actually highly recommended for older adults too. And that's typically going to happen at 30 to 60% 1 rep max for 6 to 10 reps. Look it all over a few times. Again, not essential to memorize exact numbers. You just don't want to get these kinds of questions wrong on the test. They're multiple choice. You just got to kind of know them, that's all. Does current activity level affect readiness decisions? Yes, it does. And if you're sedentary or not active basically at all, it counts as a risk factor, which we're going to talk a lot more about those. But yeah, if they aren't physically active within the last 3 months, you are more likely to need clearance to avoid vigorous activity, which is 60% plus, more than or equal to 6 mets, or greater than or equal to 14 on a 6 to 20 scale, so on and so forth. So exercise order is also very good to know. Power exercises, oftentimes they're plyometric, but sometimes they're just very explosive, like a snatch, push press, Olympic lifts, those types of things. Those are going to be done first in your workout. So if you have a client doing a snatch, a bench press, which is a multi-joint exercise, and a single joint exercise, usually they're much simpler and just target maybe one muscle at a time. Power exercises first. Multi-joint exercises, bench press, squat, deadlift, lots of muscle groups doing their things, but they're not quite as explosive as the power exercises. They come next. Single joint exercises, much simpler, typically curls, crunches, lateral raise, tricep extensions. A lot of core moves, honestly, would go in here. Yeah, they would come last. So make sure you understand all of that. Pretty simple once you look it over once or twice. Next up, we have RPE, or rating of perceived exertion. So you can rank things on a 1 to 10 scale, which I feel like that one's pretty self-explanatory. 10 is hard, 1 is super easy. And then you can also rank things on the Borg scale, in which case 6 is very easy and 20 is very, very hard. And you should definitely know and understand all of that. So when it comes to aerobic training, even resistance training to some extent, you're going to want to start most clients off light to moderate. They should be able to talk a little bit, but not sing. Gasping for words is vigorous intensity. And again, you can kind of tell where that would come in down here. And we don't need to necessarily give exact numbers for all of these things because they don't exist. But again, you get the general idea. Now, what RPE, rating of perceived exertion, would you want for a static stretch? That's a good question. The answer in most cases is going to be about a 13 to 15 on the scale, so somewhat hard to hard. Essentially, you want mild discomfort, but you don't want pain or anything like that. So periodization is a systematic planning of physical training. The aim is to reach the best possible performance for a specific time frame or event. You achieve this by changing up exercise variables when appropriate. And some exercise variables that exist are sets, reps, time under tension. Of course, there are other things too. So for breaking down a periodized plan, an entire periodized plan is a macrocycle, and it can last up to a year or so. A mesocycle is a specific block of training to achieve a specific goal, and typically they're about a month long. And then a microcycle is the smallest, typically they're just about a week. So linear periodization is the most basic type of periodization, and it's a traditional method of program design that aims to gradually increase the intensity of the training load while simultaneously decreasing volume over a set period of time. Next up, we have undulating periodization, and this is a program scheme also known as nonlinear periodization, and it uses changes in volume, intensity, and exercise selection to provide loading differences on a daily or weekly basis. Daily undulating periodization is often known as a DUP or DUP program. So basically know that linear periodization is a gradual increase of intensity and decrease of reps, and nonlinear or undulating is more all over the place. So the weight or resistance might look like this. In linear periodization, it's going slowly up over time, and it would generally go up in undulating periodization as well, but it wouldn't be that same steady increase. General rep ranges to know, obviously we've covered this a decent amount already. General fitness, 8 to 12 reps, 60 to 80% 1 rep max. Beginners trying to improve motor performance. Basically, they're just kind of learning the exercises, they're trying to improve their form. Oftentimes 40 to 50% 1 rep max, they're kind of going pretty light. Strength gain for advanced clients, 1 to 6 reps, 80% or more 1 rep max. If you're advanced and you're really focused on strength, you're going to have to go heavy, obviously. So 1 to 6 reps, 80+% 1 rep max. Hypertrophy, 6 to 20 reps and a wide variety of intensities are possible based on new research. The newest research is showing that you can basically build muscle in a whole bunch of different rep ranges, and it doesn't necessarily matter that much. As long as the reps get tough towards the end, this is typically not too far off. Usually 8 to 12 is a pretty good hypertrophy range. 6 to 20, there's a lot of different ones. Make sure you read questions carefully on that. Other programming stuff. Less than 5 sets per week per muscle group might be enough for beginners. Yeah, if you're truly a beginner or someone who is completely sedentary, you might need like 1 set per week. Experienced lifters may need 10 plus. It's going to vary a ton based on who you're working with. 2 to 3 non-consecutive days for beginners, for sure. They don't need that much volume. More advanced can do more. Typically, it's going to be more. They can also do less days too if they're really pushing that intensity super high. Rest, 2+ minutes between sets for heavier weight or bigger exercises. If you're doing heavy barbell squats, you're gonna need a pretty long rest to recover enough to, hit that squat hard again soon. You guys know what I'm talking about. Same goes for the Olympic lifts, those super intense moves. You need bigger breaks. 1 minute, give or take, for some of the other moves. If you're doing a bunch of bicep curls, yeah, you probably don't have to take as long of a break there. If you're working specifically on hypertrophy, muscle gain, or endurance, shorter breaks sometimes make more sense, and ACSM does want you to know that. So now we're moving on to pre-participation health screening. And as you might have guessed, there are some forms here that we have to focus on. First up, we have the PARQ, and this is a subjective yes or no questionnaire that is used to determine whether it's safe or not for a client to begin an exercise program. It does have some follow-up portions to reduce false positive readings. And again, the most important things for you to know here, it's yes or no. And again, there are some additional portions. So yeah, all good things for you to either memorize or know very well. Now we're talking about the health history questionnaire, also called the HHQ, or the health history evaluation. It has a few different names. It's pretty similar to the PARQ, but it's not yes or no questions. It gets you more detailed information on your client. Things like what medications they're taking, family history, etc. are covered. PARQ and PARQ Plus are very similar. When I mention either, assume I'm talking about both. The PARQ Plus is just the better, newer version, meant to be used by anyone, not just people with conditions. Make sure you know that. A yes on the PARQ is possibly a reason to refer out before beginning exercise. If they answer no to all the follow-up questions after the first page, and really this is more so the PARQ Plus. Anyways, if they do that, they can begin light to moderate intensity exercise before seeing the doc. So a yes on a follow-up page means you should refer out first. And this is why the PARQ, really more so the PARQ Plus, because the PARQ Plus is the one that actually has the follow-up questions. It's why it's such a useful tool for starting out an exercise program, because it clears your client and it keeps you out of trouble, keeping your client safe. So you also have the informed consent, and that's all about ethical and legal stuff, and the client should be signing that before starting. Then you have the medical clearance form, and if something came up in the PARQ or the health history evaluation or questionnaire, this would be done. And if someone does have some concerning medical stuff going on, having their doctor and that client sign one of these before beginning an exercise program, well, that's just a good idea, and it's something we'll talk about more in the rest of this video. So the informed consent is an important one for you to know. This gives clients information about the content and the process of the program that you're going to be delivering. So some essential elements or things that you would find in the informed consent are a detailed description of the program, the risks and benefits of the program, a confidentiality clause, responsibilities of the client or participant, and documentation or acceptance of the form itself. What informs the client about the risks of exercise? It's actually kind of obvious since the answer is right there, but it is the informed consent. It is the thing that lets your client know that there is risks associated with exercises. Make sure you know that. Your client says yes to something on the PARQ Plus. What happens next? Answer the eparmed-x, which acts as a follow-up to the PARQ Plus, the physical activity readiness questionnaire, and it helps you determine if a person needs a physician's clearance before beginning. That's pretty much all it is. It's just an extra form. Good to know what it is, not as widely used as the PARQ Plus itself, and it does actually see more use with pregnant women. Maybe that's good to know as well, but yeah, just know what it is. It's a follow-up to the PARQ Plus. Moving on to consultations and behavior change. So let's kick this section off with the Transtheoretical model, and this is something you're very likely to get at least one question about. By the way, there are 5 stages to the Transtheoretical model. So those 5 stages are pre-contemplation, contemplation, preparation, action, and maintenance. First up, pre-contemplation, and this is where people are physically inactive. They're not intending on beginning an exercise program, and they don't see exercise as worth their time. After pre-contemplation, you have contemplation, which I feel like makes sense. Here, people are inactive, but thinking about becoming more active in the next 6 months. They're still weighing the pros and cons of exercise, but they're starting to consider the benefits. After contemplation is preparation. People in this stage are doing some physical activity and preparing to adopt a more consistent activity program. These people are only doing things like sporadic walking, but they're ready to adopt an active lifestyle. After preparation, you have the action stage. People are here when they're engaging in regular physical activity, but have been doing so for less than 6 months. So remember that, less than 6 months if they've been doing physical activity. Action stage. Lastly, you have maintenance. Should say people in this stage, not on this stage. Anyway, people in this stage have been working out consistently for longer than 6 months, and just make sure you can identify where someone is in this model. So if I have a client and they've been working out consistently, but just for 2 months, Technically, they would go in this action stage because, again, they haven't been doing it for at least 6 months. And then, of course, if I have someone who isn't thinking about working out at all, they'd go in this pre-contemplation stage. So decisional balance is something that takes place in every part of the Transtheoretical model, the thing that we just talked about. No matter what stage of the Transtheoretical model someone is in or what stage of life they're in, they're always going to be acknowledging pros and cons of health change. For example, becoming more active could help you reverse diabetes and it could lessen your joint pain. Some of the cons that would also exist with increasing your activity: exercise is hard, and there is always a little bit of a fear of failure. Unfortunately, only a minority, usually less than 20% of a population at risk, is prepared to take action at any given time. Probably not necessary to know for the test, but still kind of interesting. So next up, we're talking about SMART goals, so specific, measurable, attainable, realistic, and timely goals, and you do want clients' goals to be SMART goals. When we're talking about specific, someone saying they just want to lose weight, well, that really might not be good enough. They're more likely to actually lose weight if they know roughly how much weight they want to lose. Maybe they want to lose 20 pounds. So again, you have to kind of figure that out with your client. Measurable is pretty easy for us because most metrics in our world are very easy to measure. Again, if someone's trying to lose weight, pounds would be the measurement that you're looking at. Obviously, if someone's main goal is to improve their bench press, you're also looking at pounds there, but now you're looking at pounds added to the bar over a period of time. Attainable is pretty simple. You want to set goals that are actually possible to achieve, so just keep that in mind. R can stand for realistic or relevant. I have realistic down here, but oftentimes relevant will also be the thing that it could stand for, so keep that in mind. Anyway, your goal should be realistic or relevant to your life or the life that you're trying to move into. And then for timely, give yourself time to achieve a goal, but you should have some sort of a deadline, even if it's just a soft deadline. Next up, we have the health belief model, and basically it states that behavior change is predicted by one's feeling of susceptibility. So basically in this model, if I have high blood pressure and I want to exercise and clean up my diet to try to reduce that blood pressure, I am more likely to change my behavior than someone who doesn't have perceived danger. So again, danger is a little bit more important than the perceived benefits of exercise or changing your lifestyle in this health belief model. And because of that, it's not as useful for those without identified health risks. Next up, we have the social cognitive theory, and outcome expectations and self-efficacy, which is basically your belief in yourself or your ability to change something, are the most important factors for behavior change. And this one considers clients' thoughts, environment, and feelings about behavior change itself. And I just said this, but hey, it's good recap. The social cognitive theory's two most important factors in behavior change are outcome expectations, so basically what you think will happen when you change a behavior. Self-efficacy is my confidence or belief in myself to get something done. Next up, we have self-monitoring, and this refers to the practice of tracking one's own behavior for the dual purpose of increasing awareness and monitoring progress. Next up, we have the theory of planned behavior, and someone's intention is a big part of this one. And basically it says intention to engage in a behavior is shaped by a client's attitude regarding how helpful / enjoyable something is, subjective norms / social pressure, and their self-efficacy or confidence. Next up, you have the social ecological model, and in that one, health behaviors aren't only shaped by the individual, environment, relationships, laws, barriers, etc. All of those things and more also have an effect. So next up, we're talking about intrinsic and extrinsic motivation. Intrinsic motivation comes from within. It's the desire to do something because the activity itself is enjoyable, interesting, or personally satisfying. Typically, intrinsic motivation is more powerful. If that motivation comes from within or from liking the activity, people are more likely to stick with it. You also have extrinsic motivation, and that occurs due to a potential reward or avoiding punishment. So if I have a client training for a bodybuilding competition and they want to look really good up on stage, well, in a way, that is kind of a reward, especially if there's a big trophy on the line. They could also be avoiding punishment. Maybe their doctor told them they have high blood pressure and they need to get in the gym to work on that. So that would all be extrinsic motivation. Typically, intrinsic motivation is a little bit more powerful. So some examples here for intrinsic motivation: hitting the gym because you like how you feel afterwards, joining a running club because you enjoy running with your peers. Again, we are increasing that enjoyment from the exercise itself, and that typically comes from within. Extrinsic motivation, doing your homework so you don't get detention. Yeah, you're avoiding punishment there. Lifting weights to look good and show off for your friends. Yeah, you are lifting weights to look good. That's the prize, right? You're looking good for your friends, looking good for your peers. It's not necessarily for your own enjoyment, but I suppose you do get some enjoyment from looking good, but it's external and it's to show off. It's a prize. So we have the self-determination theory. It's a psychological framework that explains human motivation by proposing that people are driven by three needs: autonomy, feeling free and in control of one's choices; competence, feeling capable and skilled in one's actions. Basically, are you good at doing something? And relatedness, feeling a sense of connection and belonging with others. So, self-determination theory, I'm just going to read it back to you a second time because I feel like doing that is going to help. The self-determination theory is a psychological framework that explains human motivation by proposing that people are driven by three needs. You have autonomy first, which is when you feel free and in control. You have competence, which is feeling capable and skilled in one's actions. And you have relatedness, which is feeling a sense of connection and belonging with others. So we have four different types of support. Emotional support would be the first, and an example of that could be where a friend is periodically calling to encourage sticking with an exercise program. Next up, we have tangible support, so something that is physical, and an example of that could be where a spouse is offering to cook dinner while the client works out. We have informational support, and that could be a lot of different things: emails, posters, etc. I think this is supposed to say or forms, but basically anything informational could be informational support. And there's also a lot of things that could be appraisal support, but a spouse praising progress would definitely fit that description. This is typically going to happen when someone is saying something to you that helps you build your confidence. When working with a client, the first thing you do is an initial consultation. So you're going to want to call your prospect because before the initial consultation, this person wouldn't actually be your client. You're going to want to call that person 24 to 48 hours before that first appointment. You're going to want to be on time or early. Duh. Most of this stuff is really just common sense. That being said, you definitely still should know all of this. You're going to want to be professional. You're going to want to stay in your scope of practice. And you're, of course, going to want to provide credible fitness programs. Next up, we have the principle of relationship marketing. So a personal relationship should take precedence, and if it does, sales will follow. And there's no doubt that in the real world, this is true. If you have a strong personal relationship with a prospect or a client, they're going to keep training with you and they're going to sign up initially in the first place. Also really good to know, retaining clients take precedence over signing new clients. And that is definitely true as well, because it's always easier to retain an existing client than it is to sign a new client on. Next up, we're going to talk about rapport building or relationship building. And there are some important nuggets to take away on this slide. So first off, when you're doing that initial consultation with a new prospect, you're going to want to ask simple, open-ended questions. That means don't ask any questions that can easily be answered by yes or no. Instead of asking a prospect or a client a yes or no question, you could ask something like, what has prevented you from achieving your goals in the past? This is a big one too. Listen and encourage with nonverbal cues. People often form 90% of their opinion of a person in 4 minutes, and 60 to 80% of their thoughts are based around nonverbal cues. You're also going to want to clarify and summarize. Make sure you understand what the person is saying. More on that soon. And then using reflective statements is very similar to clarifying and summarize. So again, we'll be going over all of that in a sec. Next up, we'll be talking about active listening, and this is a big one. You should be asking questions, you should be reflecting back what the client is saying, and you should be summarizing. And like we said before, observing nonverbal cues is always big. Bit of a rehash here, but again, clarifying, repeating, and summarizing what a person has said is huge. So make sure you know that. And we're talking a lot about reflections here, but that's because reflections are big. If a client says, I want to lose 15 pounds, but my husband keeps bringing home pizza, you might say something like, I understand that. Sometimes the environment you live in can present challenges. And I know I'm starting to beat a dead horse here, but whether we're talking about active listening or the client-centered approach, know that body/facial language and nonverbal cues are really important. You shouldn't be talking that much in the initial consultation. 10 to 15% of the time is about right. And that means you'll spend a lot of time actively listening, not passively listening. If they throw passively listening into a multiple choice question, which they oftentimes do, that is not the correct answer. For a lot of these initial consultation questions, the correct answer will be actively listening. So when conducting a motivational interview with your client, you would start off with this ruler right here, and you don't necessarily have to just use this ruler right when you're first starting to work with a client. You can use this at various points in time, and essentially you're just trying to gauge how ready they are to exercise or make changes. 1, not being ready at all. 10, being fully ready to exercise. We also have this kind of 4 square grid down here, which has maintaining activity and increasing activity, and essentially you're just having your client kind of fill it out to break down what they think the pros and cons of maintaining or increasing their activity are. Again, it's good to do when you're first starting to work with a client. You could also do it at other various points if they are looking to make changes. So even if it's someone you've been working with for a while, none of this is super important to memorize whatsoever. Good for you just to know what it is. Next up, we have risk factors, and this is a really important section, so make sure you're paying close attention to everything I'm about to say. Now, for all of this upcoming list, I'm going to be going over things that would be considered risk factors. You should either memorize this information or at the very least know it well enough to answer a multiple choice question correctly. So what you're seeing right now are risk factors for cardiovascular disease. So again, really important to look these over. I am going to read them off to you. So when it comes to age, if your client is a male 45 years or older or a female 55 years or older, that would count as a risk factor for cardiovascular disease. Next up, we have family history, and if your client has a first relative, so a parent, child, or sibling, with heart disease prior to age 55 if that relative is a male, or 65 if that relative is a female, if they have a first relative who's had heart disease prior to these ages, that would also count as a risk factor for cardiovascular disease. If your client is a current smoker or they quit within the last 6 months, that would also count as a risk factor for cardiovascular disease. And actually, if they live with someone who's a smoker, that secondhand smoke would also count as a risk factor. So that is a good thing to know. If your client is sedentary or they do less than 30 minutes of moderate intensity exercise 3 days a week for 3 months, if they're not doing at least that amount, they're sedentary, and that would be considered a risk factor. Next up, we have obesity, and your client would be considered obese if their BMI is greater than or equal to 30, if they have a waist circumference over 102 centimeters or 40 inches if they're male, or 88 centimeters, 35 inches if they're female. If any of those things are true of your client, that would count as a risk. Next up, we have hypertension or high blood pressure, and if your client's blood pressure is greater than or equal to 130, that would be the systolic number or the top number, or if their bottom number, the diastolic number, is greater than or equal to 80, or if they're on meds. If any of those 3 things are true, then your client potentially has hypertension, and that would count as a risk. Next up, we have dyslipidemia or bad cholesterol, essentially. And if their LDL being bad cholesterol, is greater than or equal to 130, or if their HDL is good cholesterol, if that number is under 40, because you actually want your HDL number to be on the higher side, since HDL is good cholesterol. Anyways, if either of those 2 things is true, person has dyslipidemia, that counts as a risk. Also, if they're on medication for their cholesterol or anything for that matter, count that as a risk. So if they're on blood pressure medication, count that as a risk. Now, oftentimes people are only going to know their total cholesterol number. If their total cholesterol number is greater than or equal to 200, count that as a risk for dyslipidemia, or cholesterol. Now on the bottom here we have diabetes, or let's just say the potential for diabetes. If someone's fasting blood glucose is greater than or equal to 100, that would count as a risk. Your OGTT, A1C, these ones I don't necessarily think are worth memorizing. They tend to not appear quite as often on these big tests. Maybe just look them over a few times. These are numbers that you're either going to have to memorize or at least know them pretty well enough to get a multiple choice question correct. For example, let's say I gave you this client, a male, 48 years old, they have a BMI of 29, they quit smoking 5 months ago, their fasting blood glucose is 128, their LDL cholesterol is 100, and their HDL is 50. How many risk factors would this person have? Male, 48 years old, so they're over 45, so that would count as a risk factor. They have a BMI of 29, and that is less than 30, so no risk factor there. They quit smoking 5 months ago. That would actually count as a risk factor because it's within the last 6 months. So yeah, this person was a fairly recent smoker. If it's not 6 months or longer, count it as a risk factor. And if they're right on the 6-month mark, I would still count it. Fasting blood glucose of 128. Yeah, that would definitely count as a risk factor because it is over 100. This person potentially has diabetes. They'd have to, of course, see a doctor to confirm that. And that's because we can't diagnose anything. We can't diagnose hypertension. We can't diagnose diabetes. That's not our job, but it is potentially our job. In fact, it's absolutely our job to kind of figure out if someone has risk factors and if we have to refer them out before starting exercise. So their LDL cholesterol, or their bad cholesterol, is 100, and that is not so bad. It's not greater than or equal to 130. Their HDL is 50, and that's pretty good too. That's over 40, so their cholesterol is just fine, not a risk. So their age, 48, that's going to be their first risk factor right there, so that's 1. This person only quit smoking 5 months ago, so that would be their second risk factor. And then their fasting blood glucose is 128, and that is over 100, so they have 3 risk factors far as we can tell. And on the big test, you're likely to get a question pretty similar to that. At the very least, you're likely to get 1 or 2 questions where you have someone's blood pressure and you have to kind of identify if they have high blood pressure or not. Same goes for diabetes, if they are sedentary, if they have obesity, be it their BMI, their waist circumference. So look these numbers over a few times, listen to me say them, play it back. Make sure you understand it because this is going to come up on the big test in one form or another. Low risk are people with less than or equal to 1 risk factor. So 1 or less risks, you are low risk. Moderate are people with greater than or equal to 2 risk factors. So if you have at least 2 risk factors, you are considered moderate risk, and you are high risk if you have known cardiovascular or metabolic disease symptoms, or obviously cardiovascular or metabolic disease itself. That would make you high risk. Look this over once or twice, make sure it makes sense. So we actually just talked about this briefly, but when it comes to cholesterol, you have LDL and HDL. LDL is often known as bad cholesterol, and HDL is good cholesterol. Because of that, if someone has an HDL greater than or equal to 60, it is a negative risk factor, so technically it would subtract a risk factor from their overall list of risk factors. So triglycerides are a little bit different than LDL and HDL, and if someone has a triglyceride level of 209, where does that put them? Normal, borderline high, high, or very high? Well, you probably wouldn't really know this all that much because we haven't really talked about triglycerides yet, but if their number is 209, that would actually put them at high because it's over 200. So again, these are numbers that maybe don't memorize them, but it's good to have a general idea of where someone's triglyceride levels should be. So taking a client's heart rate, typically their heart rate is going to be 60 to 80 beats per minute. You have bradycardia, and that's a very slow heart rate, which would be under 60 BPM or beats per minute. There's also tachycardia, which is the exact opposite. That's a heart rate that is high, so over 100 BPM. So there's a few different ways you can take someone's heart rate. You have the brachial artery, you have the the radial artery. This is really the one that we're going to be using the most, and that's kind of why I have its location down here. So it's the lateral wrist, beneath the base of the thumb, the carotid artery, that's your neck, got the temporal artery. Don't really need to know too much about these. Again, the radial artery, I would memorize that one's location because that's the one we use the most often. And you can get someone's heart rate in a bunch of different ways. So if you take someone's heart rate or kind of listen to their heartbeat for 6 seconds, you can multiply that number by 10. But there's a bunch of different ways you could do this. You could get their heart rate for 10 seconds and then multiply that number by 6. Doesn't really matter. You can use whatever mathematical formula floats your boat. Normal blood pressure would be where your systolic, that top number, is less than 120, and that diastolic number, that would be the bottom number, that's going to be less than 80. That would be normal blood pressure or not a risk. Then you have elevated blood pressure, and this person isn't at risk yet, but they are well on their way, and their systolic number, that top number, is going to be 120 to 129. And again, their diastolic number would still be under 80. Then you have stage 1 hypertension, and you can see the numbers there for that. Stage 2 hypertension, and again, you can see the numbers there for that. And then you have a hypertension crisis. So this is like where someone's blood pressure is very dangerously high. And again, you can see numbers here for this. And now we are moving on to taking blood pressure. And this is something you should know at least somewhat well. Do you have to be an expert? No, but you should understand the steps. You will get some questions about this. I'm just going to read them back to you guys a few times, and I want you to try to memorize as much as you can. Again, it doesn't have to be perfect. You just have to be able to get a multiple choice question correct. Anyways, blood pressure steps. Step 1, and you don't have to memorize the numbers here, you just need to know how it works. You want them in a quiet room for 5 minutes, feet on the floor with back support. You want them to chill out for 5 minutes before you take their blood pressure because otherwise it's going to be elevated. So the cuff is going to be around the upper arm and it's going to be heart level, aligned with the brachial artery. The bladder should encircle 80% of the arm. The stethoscope goes below the antecubital space over the brachial artery. You do not secure it with your thumb because then your own pulse is going to get in there. It's going to screw things up. After that, you quickly inflate to 20 millimeters over the first Korotkoff sound. And then after that, you're going to slowly reduce pressure. You're going to be turning that little dial at 2 to 5 millimeters per second. SBP, systolic blood pressure, is the point when the first 2 Korotkoff sounds are heard. Diastolic blood pressure, that's the bottom number, is the point before Korotkoff sounds disappear. Very important to know that. I'm going to read this back once more. You want your person seated quietly for 5+ minutes, feet on the floor. You want back support. They need to chill out before you take their blood pressure. After that, the cuff is going to go around the upper arm at heart level, aligned with the brachial artery. The bladder should encircle 80% of the arm. The stethoscope goes below the antecubital space over the brachial artery. Do not secure that with your thumb. Quickly inflate to 20 millimeters over the first Korotkoff sound. Slowly reduce pressure at 2 to 5 millimeters per second. Systolic blood pressure, the top number, is the point when the first 2 Korotkoff sounds are heard. Diastolic blood pressure, the second or bottom number, is the point right before Korotkoff sounds disappear. Look it over a few times, listen to me say it a few times, and you'll know it well enough for the big test. Blood pressure considerations. No caffeine or cigarettes 30 minutes prior to testing. They can raise blood pressure. Many adults will need a larger cuff. Yeah, if your arm is too big, it's not going to work, so you might need a larger cuff. At least 2 measurements should be taken at least a minute apart, and that's because if you take them too close together, they can kind of mess each other up since they're squeezing your arm so much. The average is then taken. Blood pressure should be measured in both arms during the first exam, and you want to use the higher pressure. Give patients their blood pressure numbers verbally, and you want to give them some written goals, perhaps, especially if their blood pressure is a little bit high. We can't technically diagnose that. A doctor does that, and it takes multiple readings. That being said, if someone's blood pressure is coming up high, and it's coming up high a few times, it's something worth talking about, and it's something worth addressing. More risks. So left ventricular ejection fraction, if it is below 40%, that would be a risk. A survivor of cardiac arrest, that would also be a risk. angina pectoris, which is essentially chest pain, usually obviously associated with the heart. Yeah, that's a risk. Dizziness, lightheadedness, of course, risks. Dyspnea at low-level exercise, breathing issues essentially. Yep, for sure. Functional capacity less than 5 METs. Clinically significant depressive symptoms. These would definitely all be considered risks, so make sure you look these over once or twice and make sure you understand them. BMI or body mass index, this is an interesting one. So you have two different formulas you can use here to calculate someone's BMI, and that is something that you might actually have to do on the big test. Personally, I like this bottom formula more, and that's because you don't have to worry about meters or anything like that. So again, this bottom formula is usually my go-to, and you can see I actually plugged my information into this equation down here. So 703 times 180, I weigh 180 pounds. I am 5'10", so 70 inches squared. And then if we multiply these two numbers together and divide that number by the square root of 70, we get 25.82, and that would be my BMI. And I'm not saying like I'm some physical specimen or something like that, but this is me just a few months ago. I look the same now. And yeah, I'm clearly in at least halfway decent shape and not overweight. And that is the thing you need to know about BMI. BMI doesn't take body fat percentage into consideration at all. BMI is all about your height and your weight, and that's it. So if you're someone who has a lot of muscle mass, like The Rock, for instance, you're almost certainly going to end up in this obesity category, which again, we all know The Rock isn't actually obese. He has a ton of muscle mass on his frame and incredibly low body fat. So BMI is kind of one of those weird things, but again, you might need to calculate someone's BMI on the big test. I don't necessarily think you need to memorize these numbers, but there are a few important ones here. So if someone has a BMI under 18.5, they're considered underweight. If their BMI is between 18.5 and 24.9, they're in the healthy range. If it's between 25 and 29.9, they're considered overweight. If it's between 30 and 39.9, they are obese. And if it's 40 or over, they are severely obese. I would memorize that 30 and over means they're obese. I would memorize that 25 to 29.9 means they're overweight. And I would also memorize that 18.5 and under is underweight. And then if you kind of know those pieces of information, you can figure everything else out. Next up, we'll be talking a little bit about ACSM's health screening recommendations. And I have a link down here because I think this is the best way to learn what they recommend. So if you have a new client or prospect and you're trying to figure out whether or not that client is ready to begin an exercise program, this is where you'd want to go. Anyways, does the individual currently exercise? If it's a yes, does he or she have cardiovascular, metabolic, renal disease, or signs or symptoms that he or she does? If it's a no, no medical clearance necessary to continue to moderate or vigorous exercise, which may progress, blah, 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 blah. Basically, this person can work out. If the answer is yes, no medical clearance necessary to continue moderate exercise, gradually progress to vigorous exercise if there's no change in symptoms. If there is a change in symptoms, you might have to send that person to a doctor. But if they have asymptomatic cardiovascular, metabolic, renal disease, essentially they're not having any issues, yeah, they're good to begin exercising. So if this person doesn't have known or asymptomatic cardiovascular, metabolic, or renal disease, if they don't have that, so we say no here, do they have signs or symptoms suggestive of cardiovascular, metabolic, or renal disease? If you say yes to that question for whatever reason, discontinue exercise and seek medical clearance. Basically, you're going to have that person go see their doctor before doing anything too crazy, or really just before any type of exercise at all. So let's go back to the initial question. Does the individual currently exercise regularly? If you say no, then you have to go down here. Does he or she have cardiovascular, metabolic, renal disease, or signs or symptoms that suggest they do? If they do have any signs or symptoms, medical clearance is recommended before you do any type of exercise. So what would be some signs or symptoms of cardiovascular, metabolic, or renal disease? Well, chest pain or tightness would be a very obvious sign of possible cardiovascular disease. If someone is having claudication or some swelling of the lower part of their leg, that could also indicate some circulatory issues or cardiovascular problems. To be honest, there's quite a few things that could qualify as symptoms for one of these three things: cardiovascular, metabolic, or renal disease. Anyways, if they don't have any signs or symptoms going on, no medical clearance is necessary. Light to moderate intensity exercise is recommended. And of course, this person can gradually increase things as they move forward. Now, I wouldn't memorize everything that we just went over on this chart, but maybe look it over a few times and make sure you understand it. Signs and symptoms of cardiovascular disease. Pain or discomfort in the head, neck, chest, jaw, and arms. Dyspnea, which is difficulty breathing at rest or during light exercise. Syncope, which is fainting, lightheadedness. Orthopnea, which is trouble breathing while lying down. And these are just good terms for you to know, and this is actually partially why I put this in here. Ankle edema, that is swelling that indicates bad stuff. Yeah, circulation problems is really what it indicates. Palpitations and tachycardia. Yep, you don't want those. Tachycardia is just a really high heart rate. Intermittent claudication, that is calf swelling and pain, and it typically kind of gets worse with exercise. Not always, but almost always. Heart murmurs, yeah, they should be evaluated, not by us, by an actual doctor. Unusual fatigue or shortness of breath. All signs and symptoms of cardiovascular disease, and make sure you understand what these terms are. When is someone high risk? When they have one of the following below: a heart attack, heart surgery, or catheterization, etc., pacemaker, defibrillator inserted in there, heart valve disease, heart failure, heart transplant, renal disease, congenital heart disease, type 1 or type 2 diabetes. Of course, any of these things would make someone high risk. Look them over a few times. I think they're pretty much common sense. And then I always think it's really good to say, when in doubt, refer out to a doctor. It's almost always a good idea if you're unsure of where to go. Next up, we're going to be talking about mathematical equations that you should know for the test. I won't be breaking every single thing down that ACSM shows in the book. That being said, I will be covering a good amount of it. METs are metabolic equivalents of a task, and METs are actually pretty similar to calories. METs tell you how much exercise is being used or the intensity of a certain activity. And these are probably not worth memorizing. Very light intensity would be under 2 METs. So if I'm sitting on a couch, usually I'm just using like 1 or 2 METs at the most. Light intensity would be 2 to 2.9 METs. And again, you can see RPEs here, which we just talked about. And we could just keep going down the list. All right, so let's say we have a guy rowing at 7 METs 3 days per week for 30 minutes. What are his rowing MET minutes per week? Well, if you have to figure out how many MET minutes of exercise someone is doing in a week, it's actually pretty easy. Basically, you just multiply all these pieces of information together. So 7 METs, which you can see down here, times 30 minutes, which that's how much he's doing each day. And then he's doing it for 3 days. So if we multiply all those things together, we get 630 MET minutes per week. And that's good because 500 to 1,000 MET minutes per week is recommended. By the way, guys, on the big test, you will have access to a calculator. It's kind of one of those dinky little built-in ones to the software, the testing software itself. It gets the job done. It works out just fine. Converting METs to calories, this is something you might have to do on the test. It's good for us to go over it here just in case. So 1 MET is equal to an oxygen uptake of 3.5 milliliters per kilogram per minute. Whatever, just know that 1 MET equals 3.5 milliliter blah, 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 blah. Anyways, this formula down here, which don't bother memorizing this, but yeah, this is how you would take METs and convert it into kcalories per minute. So if we took our rowing guy from before, and let's just say he weighs 70 kilograms, and let's plug his information into this equation. So he said before that his rowing is using about 7 METs. Here's the 3.5 that we talked about before. His weight is 70 kilograms. So we just multiply all these things together, divide that by 200, and that gives us about 8.6 kcals per minute. Keep in mind, he's rowing for 30 minutes 3 times a week. Again, we kind of figured that out in this example before, so we're just using the same guy. So back down to here, and again, we said 30 minutes 3 times a week, so 8.6, that's his kcals per minute, times 30 times 3, equals 774 kcals per week. And again, this number is only important if you're asked to figure out how many kcals someone is burning in a week. If you were asked about how many kcals someone is burning in a minute, again, this is where you would stop right here, and so on and so forth, converting METs to calories. Again, you might not have to do any of this other stuff. It just depends on what kind of questions you get on your test. Anyways, this is actually kind of important to know. To convert pounds to kilograms, do pounds times 0.454, and that will give you kilograms. So if I do 180 times 0.454, again, that equals 81.72 kilograms. Next up, we have the mechanical work formula, and again, not worth memorizing, but good for us to go over just in case you get a question about this on the big test. Basically, the way this one works, force times distance, and then you're going to take those two numbers, multiply them together, and then multiply them by sets and reps. So again, if we look back at this formula, force times distance, blah, 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 135, that is the weight or the force that we're having to move, distance 3 feet, sets and reps right here, and we actually get this pretty big number, 6,075. So yeah, that's how you would do that if you get a question like that on the test. This slide right here is a very important one. So someone's max heart rate, there's a few different ways to get it. 220 minus your age, that is the most simple way to get someone's maximum heart rate. So that is the maximum heart rate that they can achieve during exercise. So let's say I'm working with a client who's 20 years old, 220 minus 20 is 200. So 200 would be that 20-year-old's maximum heart rate. There's other formulas that you can use to get someone's maximum heart rate. Here is one right here, and I won't lie to you guys, some of these other formulas are actually a little bit more accurate. But whatever, for our purposes and in taking this test, this 220 minus age is pretty much always going to be good enough. And it's also good to keep in mind that there are some heart rate intensity ranges. For example, the light intensity range would be 57 to 63% of your maximum heart rate. So if we took that 20-year-old we were just talking about and we were trying to figure out where they would be in this range, we would do 220 minus 20, that would give us 200, their estimated max heart rate. We would take 57% of that and 63% of that 200, and that would give us this range for that person. And this is what I was just talking about before, but now with moderate intensity, so the range there is 64 to 76% of HR max. So if we had a 28-year-old and their max heart rate would be around 187, and then we would take 187 times 0.64, that gives us 120. And then if we did 187 times 0.76, that gives us 142, and that gives us their range here, this moderate intensity range. For apparently healthy individuals, you will often want to use a heart rate range of 70 to 85%. Sometimes it could be 64 to 95%. It depends on the client and their goals. Heart rate reserve is an important one, and you calculate your heart rate reserve by subtracting your resting heart rate from your maximum heart rate. Once you do that, you may need to calculate a percentage. So if I'm training a 25-year-old, their max heart rate would be about 195, 220 minus 25 their age, again gives us 195. Let's say their resting heart rate is 65, so we would take that 195, their max heart rate, subtract their resting heart rate, 65, and that gives us 130. So now we're going to talk a little bit more about heart rate reserve and target heart rate. So the formula for target heart rate is right here, and basically heart rate reserve times the intensity percentage that you're looking for, and then after that you're going to add resting heart rate back to that number. So if we took that 130 heart rate reserve from the last example and we multiplied it by 0.4 or 40%, which would be the low end of moderate when using heart rate reserve to calculate intensity, and then we added back that person's resting, which is 65, we get 117 beats per minute. And then if we did the same thing with 0.89 or 89%, which would be the upper end of vigorous when using heart rate reserve to figure out intensity, we'd get 181 beats per minute. Just like with the other mathematical equations, I don't think you need to memorize this formula. That being said, you should know roughly what it is. That way if something pops up on the test, you have an idea of what to do. You gotta be kidding me. We got another math question here. All right, so your client has a VO2 max of 50 milliliters. They're looking to exercise at 60% of their VO2 reserve. What would be their target VO2? Would it be A, 30.8 milliliters, B, 31.4 milliliters, C, 33.6 milliliters, or D, 35.8 milliliters. So VO2 max testing, it's something that 99.999999999, I don't know, maybe not that much. It's something that almost none of you will ever do because you need laboratory equipment. But yeah, it is a good test to have done, and it's a good thing to know if you're a very serious endurance athlete. It's actually a really good marker of overall health, fitness, blah, blah, blah. I'm just buying you guys some time. because there's some decent amount of math going on in this one here. And we're going to go over it very shortly. Okay, so the best answer to this question is 31.4. So VO2 reserve is VO2 max minus 3.5. Target VO2 is VO2 max minus VO2 rest times the percent intensity that you're looking for, and then you're going to add VO2 rest back to that. All right, so 50 is this person's VO2 max, so we're going to start off with that. We're going to go 50 minus resting VO2. So 50 minus 3.5, because 3.5, oops, no. 50 minus 3.5, because 3.5 is resting VO2. That gives us 46.5. Now we take that number, their VO2 max minus resting VO2, and we multiply that by the percentage that they're looking to exercise at. So we go 46.5 times 0.6. What do we get? 27.9. Now to get the answer, we add back resting VO2. So we go plus 3.5. And look at that. 31.4. That is how you get this answer. Now, just like in that last question on target heart rate, there is a very good chance that you're going to get a question about target VO2 or VO2 reserve. I'm going to show those formulas up on the screen one last time. And just like with target heart rate, if you have basic math skills and you know these formulas at least somewhat well, you're going to get the question right. Now, are these formulas worth memorizing? You know, you're going to have to kind of base that on what you feel like you're capable of learning. Yeah, I'd memorize them, or at least know them fairly well. That way you can quickly plug these guys in on the big test and get that question right. So BMR is basal metabolic rate. Essentially, it's the minimum number of calories your body needs to perform essential life-sustaining functions like breathing, circulation, cell production. It is approximately 60 to 70% of the calories that your body is burning. It's going towards BMR, just keeping you alive. We have a few different formulas here for determining someone's BMR. Let's calculate my BMR just for funsies. Hey, it could pop up on the test. We got to get my weight in kilograms first. I weigh 185 pounds. So we go 185 times 0.454. 84 kilograms is my weight. So we go 84 times 10, which is going to be 840. 840 would be what goes in this first part right here. Next up, we have to figure out my height in centimeters. I'm 70 inches tall, 5'10". So we go 70 times 2.54. So we're going inches to centimeters. So yes, hopefully you all understand what I just did there. 70 inches tall because I'm 5'10" times 2.54. That's going to give me my height in centimeters, 177.8 times 6.25, because that's what we got right here. This is the number that we get in this part right here, and we can just add 840 to that because we know that's what we got in the first part. So we got 1,951 for these first two parts right here. Okay, so next up we have to figure out this part right here. I'm 35 years old, so 5 times 35, 175. So we're gonna subtract 175 from the stuff we got over here. You should also have some scrap paper when you're taking this test, so it's gonna be a little bit easier to kind of do this with some scrap paper. Anyway, so we're gonna subtract 175 because that was what we got here. And then we're going to add 5 to that because that's the last part of the equation. And my basal metabolic rate, how many calories roughly, this is not an exact measurement, but how many calories I roughly need to stay alive, it is 1,781 calories. Hopefully, you all understand what we just went over there. Also, I really do prefer these top two equations. These are the two that I would recommend using on the actual test. Next up, we're figuring out TDEE, or total daily energy expenditure. And essentially, you'd multiply your BMR by an activity factor to get this number. If you're sedentary, you would multiply that BMR number we just got by 1.2. I would say I'm probably very active, so I would just take that number in the last slide and multiply it by 1.725. Should we memorize these numbers? Probably not, but I think it is good to have a general idea of how to do all of this stuff. And again, this is another one where if you did memorize it, it certainly wouldn't be a bad thing. How likely is TDEE to come up on the big test? It's pretty likely in one form or another. You should definitely know what it is. Total daily energy expenditure, including activity. Definitely know what it is. Definitely know what BMR is as well. BMR is also sometimes called RMR, or resting metabolic rate. Pretty much the same thing. They are 55 to 75% TDEE. These numbers will vary a little bit depending on the source, but they're roughly pretty much always here. There is a thermic effect of food. That's right. Every time you eat food, it actually costs calories to use those calories as a fuel source. So you're expending 7 to 15% of your calories in your body processing incoming calories. Some foods actually cost more calories to burn as fuel, protein being a good example there, but that's not something we have to know a ton about for right now. We also have the thermic effect of physical activity. It's usually about 15 to 30% of total daily energy expenditure. It could vary even a little bit more than that. It is good to have an idea of what these numbers are, and good to know what these all stand for as well. So now we're going to be looking over steps to calculate calories burned using VO2. And to do this, we have to figure out absolute VO2, and then there's a few additional steps beyond that. Let's look at an example on the next page here. We're going to bounce back and forth between these two pages. So a client weighs 154 pounds or 70 kilograms and has a VO2 max of 40. How many kcals will the client expend if they exercise for 30 minutes? Let's go back to the previous page and we're going to plug that information in. So 40 would go here because that is the VO2. Weight in kilograms, we already know it's 70. So if we go back here, 40 times 70, and then we would divide that by 1,000 and we get 2.8. So 2.8 would be the absolute VO2. From there, we'd want to multiply that number by 5, and that would give us calories per minute. Absolute VO2 times 5 gives us calories per minute. Okay, so we're going back here. We have the weight in kilograms. We have the VO2 that was given to us in this question. You're going to be given at least probably one question like this. So we got 2.8, multiply that by 5. They are exercising for 30 minutes. That gives us their total calories burned. Let's go back and review one more time here. We had 40 here, we had 70 here, we divide by 1,000. After that, we multiplied by 5, all kind of very clear to follow. And then we need to multiply the calories by the total number of minutes of exercise, which we did have here. 420 calories is the answer. Ideal body weight is commonly calculated using the Divine formula, which determines a healthy weight based on height and gender. So let's plug my information in here real quick. We have 50 kilograms plus 2.3 kilograms for each inch over 5 feet. I am 70 inches tall, 5 feet is 60 inches, so 10 inches taller. So 2.3 times 10, we don't even need to use the calculator, that is 23. 23 plus 50 is 73 kilograms. That would be my ideal body weight. As you saw earlier in the video, I am not 73 kilograms. If you lift weights and you have some muscle mass on your frame, you're probably going to be heavier than your ideal body weight. It's not a great thing to necessarily go by. It's primarily used for drug dosing. If you lift weights, you're probably going to be higher than your ideal body weight. Just good to know for the test. So something that's pretty likely to pop up on the test is you could have a client walking, running, cycling, whatever, and you have to figure out their VO2. There's a very high likelihood that they're going to give you this formula, so maybe it's not worth memorizing. In fact, I would say probably don't bother memorizing it. Anyways, you're going to have to figure out VO2 and you're going to have to use a formula to do so. Let's go over that at least a little bit. So a client is running at 6 miles per hour and at a 5% grade. How much oxygen are they using per minute? So we would go back, and obviously we can kind of see it solved here, but let's kind of of take it piece by piece. They're running, and they're running faster than 5 miles per hour. So this formula right here obviously is the one we would go with if they were walking. This one, cycling this one. We got this guy right here that we have to contend with. So we're going to go back to here, and essentially we have to kind of piece everything together. So how did I get 160.8 right here? Well, let's go back to this one. Essential conversion factors. These are all conversion factors that you should just know for this test. Unfortunately, there are quite a few actually, and we've gone over most of them already, at least to some extent. Haven't really covered energy or power, watts, stuff like that. Not as big on the test. It's possible that it could come up. You might have to look that one over a little bit on your own, but everything else we've pretty much gone into at this point. 1 mile per hour equals 26.8 meters per minute. We need to know this. So this 160.8 is just 6 miles per hour times the 26.8, because miles per hour, 2 meters per minute, we have to essentially multiply by 26.8. And then from there, it's kind of just plugging everything else in and then just doing some pretty basic math. So anyways, 0.2 times 160.8, and then we would solve that. We get 32.16. We got 0.9 times our speed in meters per minute. We already kind of calculated that. And then this is the grade. We're at a 5% grade. So we'd multiply by 0.05. And then once we solve all this, we get 7.236. And then we would add back this 3.5. That's resting VO2. And if we calculate all of this out, we get almost 43 milliliters per kilogram per minute. And that is how much oxygen they're using per minute. It is good for you to understand everything we just did there. Check my math, make sure it makes sense. Once you essentially convert this to meters per minute, which again, we would take miles per hour, multiply by 26.8. It really is pretty easy if you have a calculator and maybe a little bit of scrap paper. Typically going to be given a grade. You got to plug that in over here. If we go back to the formula, we can see it right here. G is grade. Good to know these formulas, probably not worth memorizing like we've already said. And hopefully all of this helps you get most or all of those math questions right on the big test. Next up, we're getting into assessments, and we have quite a bit to discuss here, and a lot of this stuff is pretty important. You would start things off with the pre-participation screening. These are essential for safety, the PARQ plus, that type of stuff, really just forms in general. You're starting with that first. After that, you go to resting measurements, heart rate and blood pressure. You want to take those early on because anything physical or even kind of nerve-wracking stuff like body composition, well, that can make these go up. Body composition would be after resting measurements, so BMI, waist to hip ratio, skin folds, anything like that. After that, you would move on to the cardiorespiratory stuff, submaximal or maximal testing. Then you'd move on to muscular fitness, and typically you would start with strength stuff. You could do strength or endurance first, I suppose it depends. And lastly, you would go into flexibility stuff. So good to look this one over a few times. So there's definitely an order of operations when it comes to assessments or a sequence of fitness assessments. The first thing you're going to want to do are the resting cardiovascular measurements like blood pressure, for instance. And that's because if you did a lot of these other things first, it would actually kind of mess with those blood pressure or heart rate readings. Next, you'd want to do anthropometrics and body composition. Anthropometrics, those are circumference measurements. We'll talk more about those soon. Body composition, also going to talk more about that soon. That would be like skin calipers or bioelectrical impedance. There's a whole bunch of different cardio fitness assessments. Again, we'll be talking about those shortly. Same goes for muscular fitness assessments. And last, you'd have flexibility or movement assessments. So you have subjective and objective assessments. Subjective assessments would be things that reflect what an individual feels. PARQ, Health History Questionnaire, RPE. Again, this is your client telling you how they're feeling. Objective things are quantified through data collection, blood pressure, heart rate. These are things that you, the professional, will actually have to get by using tools to measure. Moving on to skin fold next. We don't have to know this super well if you're going to actually do it with clients in the real world. Much like blood pressure, you would review it a few times, you'd practice it a few times using your book or the internet, blah, blah, blah. For the test, what we have to know, there are 9 possible sites: the abdominal, biceps, triceps, chest, pecs. the calf, mid-axillary, subscapular, suprailiac, thigh. 3 site locations for men, so there are a few different ways to get someone's estimated body fat percentage with skin fold. You could use the 7 site, which all these underlined ones here, that would be the 7 site. So abdominal, triceps, chest or pecs, mid-axillary, subscapular, suprailiac, and thigh. Those are the 7 sites for the typical 7 site method for getting someone's body fat percentage using skin fold. There's also the 3 site method. For men, you would take the chest, abdomen, and thigh. And for women, you would take the triceps, suprailiac, and thigh. It's good to know a few things here. Probably good to know what the 7 sites are, and probably good to know what the 3 site locations are for men and women. It's probably also good to know certain things like, for example, the triceps. When you're taking that, it's a vertical fold. Stuff like that. The mid-axillary, it's a diagonal fold. Maybe good to know. Do you have to be an expert for this test? Definitely not. What I would say is it is good to look over caliper guidelines a few times on page 210 in your book. It's just a good one to have a general idea of what's going on. And this is one that is good to look over, but not to memorize. These are just norms for body fat percentage for men and women. So if I am a 30-something-year-old dude, well, if my body fat is, let's say, 14 or 15, I'm going to be somewhere in this range right here. I'm going to be above average, almost an excellent. So yeah, you just have to kind of know generally where someone would be. If I am a 55-year-old dude with a body fat of 25.7, well, that means I'm below average, right? Again, have a good idea of maybe where people should be. You definitely don't have to memorize all these numbers in the chart. That would be insane. Just look it over a few times and you should be good. Bioelectrical impedance is an interesting one. Basically, if you have one of those scales or one of those handheld things that's telling you your body fat percentage, it is using a technology called bioelectrical impedance, or BIA. So the way it works is it basically determines your body composition based on the rate at which an electrical current travels through the body. Body fat or adipose tissue causes greater resistance, impedance, than fat-free mass and slows the rate at which the current travels. It does require specific testing arrangements. And a lot of this just comes down to hydration. If someone is dehydrated, they're going to show up as fatter than they actually are. If someone is overhydrated, they're going to show up as leaner than they actually are. Moving on to circumference measurements next, it's probably good to know what ACSM recommends, at least for this EP exam. We got the forearm, we got the calf, we got the mid-thigh, we got the abdominal, we got the waist, we have the underneath the gluteal folds here. So I guess we could call that the hips, or maybe the hips thigh. We got the hips butt, which is kind of that wider point up above. Just look these over a few times. We don't necessarily need to know the exact specifics here because that's just not likely to pop up on the test, but look them over a few times, maybe check it out in the book. Good to have a general idea of what they recommend. So if you're trying to figure out someone's 1 rep max for a bench press or the squat or maybe a leg press, you typically follow a protocol just like this. Do we have to memorize this? No. In fact, I would say it'd be kind of silly to memorize this. If you're going to actually do it with a client, you're going to use the book or some other resource, but we need to know it at least somewhat well for the test because you could get a question about it. 5 to 10 minutes warm up with light cardio, that comes first. After that, we would do a light warm up of the exercise to be tested. So if I'm doing a barbell bench press, I might just do some reps with the bar. Next up, moderate load with 50 to 70% estimated 1 rep max. You don't know what it actually is, so you kind of have to do some guesswork. Then you're going to attempt the 1 rep max. You're going to rest for 3 minutes before the next trial, assuming you didn't figure it out. Anyways, were you successful? They actually got the rep increase by 5 to 10% for an upper body like a bench press, 10 to 20% for a lower body like a leg press. Are they still successful? Great. Rest for 3 minutes, and you have to keep going with this process until you figure out their actual 1 rep max. Not worth memorizing. good to listen to me say it a few times, good to look at it a few times, so you know if something pops up on the test. When in doubt, don't do these assessments with people. Again, 1 rep max bench press assessments are not going to make sense for everyone. Also, don't have your clients do the Valsalva maneuver. And that's basically while you're breathing out through your mouth while holding your nose tightly closed. This creates a forceful strain that can trigger your heart to react and go back into normal rhythm. On to the max push-up assessment, and in this one the client is going to lower until the chin touches the mat. The person's back must be flat and the person must go to a straight arm position, so essentially they're pushing up until their arms are fully straight. And the test is over when the person forcibly strains or can't do 2 good reps in a row. And in this assessment, men would be doing full push-ups and women would be doing kneeling push-ups. Submaximal versus maximal. Some maximal things would be open circuit spirometry during graded exercise, and that's a test to fatigue. So essentially they're going all out. You could do this on the treadmill, the cycle ergometer, the arm ergometer, etc. Basically, they are going to the point that they can't go anymore, and this is a little bit more accurate for figuring out someone's VO2 max. Submaximal, A-strand rhyming using the cycle ergometer. Basically, you are going to be estimating their VO2 max because they're not going full out, so you're going to be using some calculations. Maximal or submaximal, we got the Queen step, the Harvard step, A-strand rhyming step, the Rockport walk, the 12-minute run/walk, the 1.5-mile run test. It really depends on your client. They could be maximal for some clients, they could be submaximal for others. The whole idea here is that we're trying to figure out someone's VO2 max. And some tests, the maximal ones, they basically go until they can't go anymore. And the submaximal ones, well, those ones you kind of estimate. And then you have some that can kind of be either or, just good to look them over, not necessarily one to memorize. So VO2 max is the most valid measurement of aerobic fitness, also known as maximal oxygen uptake or peak VO2. This is not something that will be done with typical clients. And now we are looking at VO2 max charts. And the bottom chart here is for men, the top chart here is for women. It's just good for us to have a general idea of where someone would be. If a guy is in their 30s and their VO2 max is 40, that would technically put them into this good category. Should we memorize every number in here? Of course not. We should have a general idea of what a good VO2 max is based on gender, based on estimated age ranges. If you are a female and you're 25 and your VO2 max is, let's say, 41, that puts you in this excellent category. Again, just good to have a general idea of where people should be. Online, you might find some different numbers, but again, we don't have to be exact here. We just have to know some general numbers, have an idea of where someone would be or should be based on their age, gender, blah, blah, blah. Moving on to the 1.5-mile run test. This is best for fitter clients, which makes a lot of sense. You wouldn't want to have someone who's totally out of shape trying to run 1.5 miles. It estimates aerobic fitness levels by scoring the individual's timed performance or their heart rate response, which is used to estimate VO2 max. Good to know that this one can help you estimate VO2 max. Next up, we have the Rockport walk test, and this is a 1-mile walking test also to predict VO2 max. Since this one is walking and not running, it is appropriate for new exercisers, which is good to know. It's likely not going to work as well for fit individuals though, and it can be done on a treadmill, which you can see right over here. By the way, someone's mile time and heart rate are what are used to predict the actual VO2 max here. Next up, we have the Queen's 3-minute step test. Nothing really worth memorizing here. It's a 16.25-inch step. Males do this test at 24 steps a minute. Females go at 22 steps a minute. And after 3 minutes, someone's heart rate is taken for 15 seconds. You're going to multiply that number by 4. And then you're going to enter that information into a formula, and it's going to give you your estimated VO2 max. Some of these assessments aren't quite as important. You have the single-stage treadmill walking protocol. And this is an effective way to predict cardiorespiratory fitness in healthy people between 20 to 59 years old. There's also the single-stage treadmill jogging protocol. And this is an effective way to predict cardiorespiratory fitness in healthy people between 18 and 28, and it's best used with experienced joggers. Next up, we have the A-strand rhyming submaximal cycling protocol. That is a lot of words, and it is created by a strand and rhyming, which, hey, that makes sense. It's also single stage, it's simple, it lasts for 6 minutes, and it uses heart rate response, and it measures cardiorespiratory fitness. So you have the Fox single stage submaximal cycling protocol. That's 5 minutes, single stage, measures cardiorespiratory fitness, and it can predict VO2 max. You also have the timed get up and go, and this helps to determine fall risk for older individuals, and it involves getting up from a chair, walking, and sitting again. You have the Fullerton SFT, which is the most comprehensive functional assessment for older adults. Strength, endurance, flexibility, balance stuff is all included there. It's also worth mentioning the talk test, which I would not necessarily consider a typical assessment. Anyways, it is a reliable way to test intensity. Really, this is associated with the transition from aerobic energy systems to anaerobic. And basically, when a client is exercising, how well they can speak during exercise relates to how intense the exercise is. Just to give you some rating of perceived exertion ideas here, 10 to 11 is where comfortable speech is possible, and 17 to 19, keep in mind this is on a 6 to 20 scale. Speech is limited to short phrases. So stopping an exercise test or an assessment. These are things that are not worth memorizing, but they are good to look over a few times. Good to hear me read them off to you because they could pop up on the test in one form or another. Anyways, angina is chest pain. If your client is having chest pain when they're running on a treadmill or really doing anything, yeah, you're gonna wanna stop the exercise test. If they have a drop in blood pressure, we're talking the systolic or the top number, or they have an excessive rise in their systolic blood pressure. Again, that is the top number. If it's going over 250, which is super, super high, or if the diastolic, that bottom number goes over 115, super high. Yeah, if any of those things happen, drop in blood pressure, this amount or more, if the blood pressure numbers go over this amount, yeah, you're gonna wanna stop. If the person requests to stop, if they have shortness of breath, wheezing, leg cramps, claudication, which is essentially like pooling of fluid or blood in the person's legs. Shortness of breath, of course, you'd have to use your best judgment. If someone's running 1.5 miles, they're probably going to be a little bit short of breath. But these other things, yeah, they are reasons definitely to stop an exercise test. Poor perfusion, that would be a reason to stop as well. Lightheadedness, confusion, nausea, etc., all reasons to stop. By the way, poor perfusion basically means poor circulation, so some of these things could go along with that, but if someone's getting extra pale or something along those lines, poor perfusion or poor circulation could be what's going on there. If someone's heart rate doesn't go up as you're making them do exercise that is increasing intensity, or if they're just continuously exercising, yeah, that could indicate that something is going wrong. So that would be a reason to stop. Change in heart rhythm, same thing, reason to stop. Severe fatigue, verbal or just visual signs, yep, definitely want to stop. Equipment failure, yeah, if the equipment breaks, you're gonna want to stop. ACSM has also included functional movement screen things in their textbook, and there's 7 different screens here to kind of just know at least a little bit. None of these things are worth memorizing. Might be worth a quick Google search though. Anyways, you have the deep squat, the hurdle step, the inline lunge, the trunk stability push-up, the rotary stability, you have the shoulder mobility, and you have the active straight leg raise screens. So moving on to energy systems, we only need to understand the basics here. So ATP or adenosine triphosphate, that is the body's main energy source. Make sure you know that. And breaking down ATP molecules is how your body fuels itself. Keep that in mind as we move on to the next page. So your body has some different ways of synthesizing or making ATP. You have the phosphagen or creatine phosphate system, which you can see here in red. This system uses creatine stored in your muscle tissue to create ATP. By the way, only a small amount of creatine can be stored in the muscle. Creatine does actually work as a supplement because it can help you generate a tiny bit more ATP when doing short and intense movements. So you see this creatine phosphate system, it's immediate, so as soon as you start doing an activity, This guy fires up and it powers the body for about 10 seconds before it starts to peter out. This creatine system is anaerobic, meaning it does not require oxygen. Next up, we have anaerobic glycolysis, and this system primarily powers your body for 10 to 60 seconds. This range can vary a bit. It's not always 10 to 60 seconds depending on what source you're learning this information from, but it's pretty much always going to be right around that. Anyways, this system uses glucose to power the body, and you can see that right down here because it says glycolytic. This green one, the last one that we have here, is called aerobic glycolysis. Notice how I said aerobic for this energy system right here, meaning it requires oxygen. These other two were anaerobic, meaning they do not require oxygen. Anyways, this system is going to be the main one for creating ATP for anything longer than 60 seconds. Sometimes it can take a little bit longer than that for this one to fully kick online and take over. It can take up to 120 seconds or 2 minutes. But yeah, for long-term exercise, this one is generating the most ATP. And in this system, carbs or fats are used for generating that ATP or energy. And a lot of this is happening in the mitochondria, or the powerhouse of the cell. Make sure you know that the mitochondria is the powerhouse of the cell. Anyways, that aerobic system that we just talked about does have other things going on, like the Krebs cycle and the electronic transport chain. I definitely simplified it a decent amount. But these aerobic systems that require oxygen, they can power the body for a long period of time. So of course, if you're doing an endurance event, that's primarily what you're going to be using. And you're not going to get many energy system questions, maybe just 1 or 2 at the most. Because you're not going to get that many, I think it's best to know rough time frames for each system. When starting an exercise up to about 10 seconds, the creatine phosphate system typically is going to be generating the most ATP, and you should have an idea of what these other 2 systems are and when they kick in as well. Next up, we're going to be talking about planes of motion and movement, and you're definitely going to have a few of these types of questions on your test. So before breaking down planes of movement and motion, there are some basic anatomical terms that we should go over. So I'm going to read each one of these guys off first, and then I'm going to go back and explain each one in a little bit more detail. So first off, we have superior, and that's towards the head or the top of the body. Then we have inferior, and that's away from the head or lower. Then we have anterior, and that's the front of the body. Then we have posterior, and that's the back side of the body. Then we have medial, and that's towards the midline of the body. Then we have lateral, and that's away from the midline of the body. Then we have proximal, and that's nearest to the trunk or the point of origin. And then we have distal, and that's farthest away from the trunk or the point of origin. Okay, so first up we have superior, toward the head of the body. So my head is superior to my shoulder because it's higher up, and my shoulder is superior to my belly button because, again, it's further up. Inferior is the opposite of that, so my belly button is, again, inferior to my shoulder or my head because it's lower down. Anterior is just the front side of your body, and posterior is the opposite. It's going to be the back side of your body. Medial is towards the midline of your body, so essentially if there was a line like going down the center of my body like this, the closer to that, the more medial something is. Lateral will be the opposite, so going further away from the midline of the body. Proximal and distal are pretty similar to medial and lateral, so if something is proximal, it's going to be nearest to the trunk or point of origin. So you could say that my shoulder is proximal relative to my elbow because, again, it's closer to the center part of my body. You could also say that my hand is distal relative to my elbow because it's further away from this origin or the center part of my body. So next up, we'll be talking about the 3 different anatomical planes of the human body. Make sure you know what these are. First up, you have the transverse plane, and this one, as you can see, kind of divides the body into top and bottom halves. Then you have the frontal plane, and the frontal plane is easy to remember because the frontal plane divides the body into front and back halves. As you can see, this guy is kind of being cut in half by like this glass window pane or something. It's going right through this center part of his body. Then you have the sagittal plane, and this guy is also being cut in half, but this time he's being cut in half into right and left halves. So again, this is right and left halves in the sagittal plane. So we're going to be talking about movements that occur in the sagittal plane, and I have a trick for helping you remember what movements do occur in the sagittal plane, so we'll be getting to that very shortly. Anyways, movements that occur in the sagittal plane, and again, the sagittal plane is that plane that does cut the body into right and left halves. So just like before, I'm going to read these off and then I'm going to come back to each one of them in greater detail. First up, we have flexion, and that is going to be decreasing the joint angle. We also have extension, which is the opposite, increasing the joint angle. We have dorsiflexion, which is moving the top of the foot towards the shin or ankle. Basically, it's just moving your foot upwards. And then we have plantar flexion, which is the exact opposite, and plantar flexion is pretty much what it sounds like. It's moving your foot downwards. Anyways, flexion or decreasing the joint angle, easiest way for me to show you that, if I'm doing elbow flexion, basically it's going to look like a bicep curl. And as you can see, the joint here is decreasing as I'm doing that curling motion. So this is elbow flexion, because again, I am decreasing that joint angle, it's getting smaller. An elbow extension would just be the exact opposite thing. So I am increasing this joint angle now. And again, that is elbow extension, because as I'm doing that motion, this motion right here, that joint angle is getting bigger. Like we said, dorsiflexion is moving the top of the foot towards the shin. So it's basically, just pretend these are my toes, if I'm kind of moving my toes up like that. And then plantar flexion is the opposite of that. It's basically just where you're kind of planting your foot down into the ground. Okay, so the trick to remembering which movements occur in the sagittal plane, well, let's go back up to this sagittal plane, again, dividing the body into right and left halves. Do you see the direction in which this plane is going? Again, it's kind of moving forwards and backwards because it's cutting this guy into right and left halves. And maybe it's easier to kind of conceptualize that here. Again, sagittal plane, movements are going forwards and backwards. And if we look at flexion and extension here again, they are happening kind of in front of the body or in back of the body. Shoulder extension, which hopefully you can see me right now, that's shoulder extension. So it's my shoulder kind of moving backwards like that. Next up, we have movements in the frontal plane. And like we said before, the frontal plane divides the body into front and back halves. So in the frontal plane, we have adduction, which is movement towards the midline of the body. We have abduction or abduction, and that's movement away from the midline of the body. We have elevation of the scapula. Don't really need to know that one so much, but it's essentially your scapula going upwards. Depression is scapula going downwards. We also have inversion and eversion of the foot. I wouldn't even bother really learning these ones. Maybe look them up on your own time, but the chances of them being on the test, very low. And honestly, same thing with elevation and depression of the scapula. These two, however, you should know what they are. So adduction would be movement towards the midline. So you see how my arm is up here right now? Well, if I move it back towards the midline, or if I'm adding my arm back to my body, that is adduction. Again, remember, adding my arm back to my body, adduction. And then abduction would just be the exact opposite. So if I'm moving my arm away from my body, that is abduction or abduction. So adduction towards my body, adding it back to my body, abduction away from my body. And if we look at that frontal plane, that should make sense because again, this plane is moving to the right and left side of the body. Again, it's cutting you in half front and back, so it's moving to the right and left side. We can also see that right down here, moving to the right and the left, and that is what you get with the frontal plane. Lastly, we have movements in the transverse plane, and the transverse plane is probably the trickiest of the three. This one cuts the body into top and bottom halves. Anyways, in this plane we have rotation, and that's when the torso or limb moves around its vertical axis. We have pronation, and that's rotating the forearm or foot to a palm side or foot side down position. We have supination, and that's rotating the forearm or foot to a palm side or foot side up position. We have horizontal abduction or horizontal abduction, and that's moving the arm away from the midline of the body when it's elevated to 90 degrees. You also have horizontal adduction, and that's moving the upper arm towards the midline of the body when it's elevated to 90 degrees. I feel like some of these sound way more confusing than they actually are, so let me show you what they look like. So rotation can be pretty much anything. I could be doing a torso rotation type exercise. I could be doing arm circles. Again, there's lots of different examples of rotation. Pronation's a little bit more interesting. So pronation is this, when my palm is kind of just facing downwards like that. So that one's pretty easy to remember. And then supination is the opposite. So supination is my palm up like this. And the easy way to remember supination is cup of soup. If your hands are like this, supinated, cup of soup. That is what you're going to remember. cup of soup for supination. So next up we have horizontal abduction and horizontal adduction. I'm actually going to start with horizontal adduction because horizontal adduction is basically you throwing a punch across your body. So this type of motion where I'm adding my arm, because it's horizontal adduction, I'm adding my arm back to my body, and I could do it on both sides at once, and that would be a fly motion if I were doing that. That is horizontal adduction. Now horizontal abduction or horizontal abduction is basically just the exact opposite motion, and that would be almost like a reverse fly type motion. So the important thing to know about movements in the transverse plane is that they have a rotational component to them. Again, we got this funky rotation-y thing going on because transverse plane motions have rotation in them. So it's possible that you'll get a question or two where you'll be shown an exercise and you'll have to identify what movement is taking place. You will also have to identify what plane of motion the movement is occurring in. So if I show you a lateral raise exercise, can you tell me what action is taking place there? And I'll give you guys just a few seconds to think about that. So it would be abduction or abduction occurring in the frontal plane because, again, it's movement away from the midline of the body. And again, it kind of looks like this right here. So now let's check out an example that's a little bit more complicated. The squat. So during this lowering phase of the squat, you're experiencing hip flexion, knee flexion, and ankle dorsiflexion because, as you can see, the joint angles are shrinking as she's going down. Now during the lifting phase of the squat, you're experiencing hip extension, knee extension, and you're also experiencing plantar flexion. And again, that's because joint angles are increasing as she's going upwards. So during the squat, we're just looking at flexion and extension. So then, which plane of motion does the squat take place in? It would be the sagittal plane, and if we go down here, we can see flexion and extension in that sagittal plane. So you don't need to be an expert in anything we just went over, but you should have a pretty good idea of which exercises go in each plane of motion. If you know what movements like flexion and extension are, and then remember that movements also go in the same directions as their planes of motion, well, none of this stuff is too hard to figure out. And here's a good time to remind all of you that I have 3 videos that cover basic anatomy. Of course, all of these different anatomical terms are related to that. Anyways, these videos are relatively easy to follow and worth watching once or twice while you're studying for your big test. Let's check out some exercise regressions, progressions, and form. You're always going to have some of these guys on your test. Let's look at the lunge. Let's say I have a client lunging, but they're wobbly. How should I regress the exercise? Should I A, allow the client to support themselves against the wall, B, decrease the number of reps that the client is doing, C, have the client do a backflip, or D, make sure you like the video? And there are quite a few answers here that make sense. I don't know, this D one down here, that one's catching my eye for sure. Anyways, the best answer here is A, allow the client to support themselves against the wall. Decreasing the number of reps isn't a terrible option either, and some of the time that would be correct, but they're still going to be wobbly for that lower number of reps, so this one actually solves the problem. I don't know though, guys, this D answer looks pretty good too. Make sure you like the video. Anyways, let's say I have a beginner client lunging, they're doing great, and I need to make the exercise harder. How should I progress the exercise? Should I A, have the client do jumping lunges, B, tell the client to perform the movement faster, C, subscribe to the channel, or D, give the client light dumbbells to hold on to while doing the exercise? Much as I like this C answer right here, D does make the most sense. Give the client light dumbbells to hold on to while doing the exercise. Of course, A would definitely make the exercise harder as well, but that wouldn't necessarily be the first thing that you would jump to when trying to make a lunge harder, no pun intended. Anyways, let's say I have a client who's squatting and leaning too far forward. Choose the best cueing advice to give this client. Should I A, tell the client that their squat is a mess, B, tell the client to shift the weight back onto the ball of their foot, heels, and hips, C, hand the client light weights for increased stability, D, stop the squat immediately and don't have that client do them anymore. And I'm going to give you guys just a few seconds to think about that. So in this instance, B would definitely be the best answer. You wouldn't want to tell someone their squat is a mess. And if someone's stability isn't that great, you're not going to want to add weight to the equation either. And of course, D is just way too extreme, so that one doesn't make any sense. Next up, let's talk about agonists and antagonists. An agonist is the prime mover or muscle that does most of the work during a specific exercise. An antagonist is the muscle that opposes the agonist. The easiest example of this is the biceps and triceps. When I'm doing a biceps curl, The biceps are the agonists, meaning they do most of the work. The opposing muscle group, the triceps, would be the antagonist. So again, if I'm doing a bicep curl or elbow flexion, again, my biceps are doing most of the work here, and that makes them the agonist. My triceps would be the opposing muscle group here. They're on the opposite side of my arm, and typically the antagonist is going to be on the opposite side of the body as the agonist. Also, my triceps do elbow extension and my biceps do elbow flexion, and they do opposite motions. So again, that makes sense. Biceps being the agonist and triceps being the antagonist in this curl situation. So if I'm doing a leg extension, what muscle group is the agonist and what muscle group is the antagonist? The agonist would be the quadricep muscles. Again, they're the things that are kicking that leg forward. And the antagonist would be the hamstring muscles. Again, they're on the opposite side of your leg and they perform the opposite action. You also have synergists, which assist prime movers or agonists with movements. So when I'm doing this curling motion, it's not just my biceps that are doing the work there. My brachialis, which is another muscle kind of right underneath my biceps, that's also contributing. Of course, I have some forearm muscles that are also helping out there too. Reciprocal inhibition is kind of always an important one, and that's when you have the relaxation of muscles on one side of a joint to accommodate contraction on the other side. And I guess I'm just going to keep using this example because it's easy to show you, but when I'm doing my bicep curl, these tricep muscles are reciprocally inhibited, meaning they're stretched out and they just can't really do a whole lot in that position. Then you have autogenic inhibition, and this is the ability of a muscle to relax when it experiences stretch or increased tension. And this one is much more relevant when someone is stretching to improve their flexibility. This process here is going on. Moving on to Golgi tendon organs and muscle spindles. And these two things are pretty similar, but they're different in one or two ways as well. GTOs are located at the point where the muscle and tendon meet, the musculo-tendinous junction. The GTO is sensitive to change in muscle tension and speed of tension change. This causes relaxation. It senses change in the muscle as things are stretching. It's located in the musculo-tendinous junction. This is the GTO, the Golgi tendon organ we're talking about, and it causes that muscle to relax. The muscle spindle is a sensory organ that lie parallel to the muscle fibers. They also detect change when a muscle is stretching, and basically they can detect the rate at which it's stretching as well, and they cause contraction. They're located in slightly different spots, and the muscle spindle causes contraction where the GTO causes relaxation. Good to know what each one is, and you don't have to go insane memorizing both too much. I feel like you listen to me say this a few times, you are going to know it well enough for the big test. And now we are moving right along to muscle contraction types. First up, we have static or isometric contractions. These contractions occur when there is no change in muscle length. And you can see this person doing a plank over here. That would be an isometric move because, again, there's no change in muscle length. This person is just holding still. So a concentric contraction is when the muscle shortens, and an eccentric contraction is when the muscle lengthens. So as I'm doing a bench press or a push-up type movement, the prime mover, my pecs, are actually shortening as I'm pushing forward like this. So this pressing part of the bench press or push-up, that would be the concentric part of the movement because the prime mover or agonist, my pec major, is shortening as I'm pushing forward. Again, the eccentric part would be the opposite part of the lift. So on the bench press, as the bar is coming down, that is the eccentric portion of the lift because my chest muscles are lengthening on that downward portion. So the eccentric phase is most responsible for DOMS, delayed onset muscle soreness. So if you want someone to get really sore, pretty much one good way to do it is to lengthen that eccentric phase of the lift. So that downward portion of the bench press, for instance, if I do that for a longer period of time, if I go really slow motion on the way down, people are going to get more sore. Isotonic exercises, which most exercises are isotonic exercises, they're typically comprised of concentric and eccentric phases like we just talked about with the bench press or push-up. Curls, squats, rows are other examples too. Isokinetic exercises have a muscular contraction that occurs at a constant speed, and the speed of the movement is controlled. Usually specialized stuff is used. I wouldn't really worry too much about isokinetic exercises. Know what isotonic exercises are. Again, these are the typical ones that you're going to think of. They have concentric and eccentric phases, and make sure you know what isometric ones are too. All right, so now we're moving on to the nutrition section of this study guide, and as you might expect, there is some important information in this part. We are trainers or exercise physiologists, not dietitians. We don't develop meal plans for clients, and we don't do medical nutrition therapy. That being said, we can do things like help our clients to understand food labels, what certain nutrients do in the body, etc. Also, we can use the dietary guidelines developed by the government and the recommendations from myplate.gov. If there is a question about what you can legally do nutrition-wise, the answer most often will have to do with the US Dietary Guidelines or myplate.gov. Also, it won't be uncommon for a question to come up where the best thing for you to do would be to refer the client to a registered dietitian. For example, if a client has diabetes and they want to lose weight, even if it's something that you could help them with, the correct thing to do would be to refer them to a dietitian. So anyways, moving right along now, there are 6 basic nutrients. We have carbohydrates, proteins, fats, vitamins, minerals, and water. Keep that in mind. These are the 6 basic nutrients. And one thing you definitely need to memorize is that 1 gram of protein is 4 calories, 1 gram of carbohydrate is 4 calories, and 1 gram of fat is 9 calories. Like I just said, make sure to memorize this piece of information. So you have micronutrients. Micronutrients would be things like vitamins, minerals, and phytonutrients, which come from plants. You have complete proteins, and these provide all the essential amino acids. Animal and dairy proteins fall into this category. You also have incomplete proteins, and these are missing 1 or more amino acids. Plant proteins fall into this category. So we have some macronutrient RDAs, recommended daily allowances. For protein, you want 0.8 grams per kilogram of body weight for sedentary adults, and it definitely could be higher for other more active populations. For carbs, you want 3 to 5 grams per kilogram of body weight for lightly active adults, and again, that could be higher for other populations. Fat's going to be 20 to 35% of total calories. Saturated fats should only make up 10% or less of total calories. So recommended macros by age. Age 1 to 3, you're going to want about 45 to 65% carbohydrate. You're going to want protein being 5 to 20% of your intake. Fat's going to be 30 to 40%. Age 4 to 8 or adolescents, carbs, we're still looking at 45 to 65%. Protein's a little bit higher, 10 to 30%. And fat is a little bit lower, 25 to 35%. Adults, 19 plus, we got carbs, still 45 to 65%. Protein, we're looking at 10 to 35%, so slightly higher. Fat, we got 20 to 35%. You can find this on page 221 in your textbook. I don't necessarily think you need to go in there, but if you want to, it's not a bad thing to go look at a few times. At the very least, look at this slide a few times, listen to me say that a few times. Make sure you know these numbers for adults. The other two, probably a little bit less important, less likely to come up on the big test, but these ones right here, yeah, you should probably know these. Weight loss should occur at a maximum of 1 to 2 pounds a week. Obviously, this will vary a bit person to person, but people, generally speaking, are not going to lose more than this. 2 pounds a week is a good amount of weight. If someone is super overweight, maybe they would lose a teensy bit faster, but 99% of the time, or almost all the time, this is really good, and you don't want people to lose weight faster than that. Speaking of pounds, there is 3,500 calories in a pound of fat, and a 500 calorie deficit would get you roughly a pound of fat loss every week. So we got a whole bunch of different types of fats here. We have monounsaturated fats. These are heart healthy. Some examples are olive oil, avocado, peanuts. You also have polyunsaturated fats or omega-3s. These are also heart healthy, and you can get those from fish, flax seeds, and some dairy will actually have some as well. There's also polyunsaturated fats, and those are omega-6s, and these are essential for growth and development, vegetable oil, nuts, and seeds. You also have saturated fats, and these are always a little bit controversial. Health benefits are unclear. You do want to limit consumption. Animal fat, full fat dairy, and coconut would be examples here. Trans fats are no good. Typically they're artificial or created in like a lab or something along those lines. Yeah, they're bad, so just keep that in mind too. Some good quick information on this slide here, and some of this could definitely appear in your final test. So some fat-soluble vitamins, you have A, D, E, and K. These vitamins are stored in fat in your body, which means you can actually overdose on these vitamins here. So A, D, E, and K. Keep that in mind. There's also water-soluble vitamins, and these ones are not stored in fat cells in the body, so you tend to just pee out any excess of these guys, and that would be vitamin C and the B vitamins. So the major minerals are calcium, phosphorus, magnesium, sodium, potassium, chloride, and sulfur. Probably don't need to memorize that one. These other two are pretty important though. You have monosaccharides. These guys are simple and can't be broken down. Glucose, fructose, and galactose would be examples there. Probably not worth memorizing, but good for me to tell you either way. Could pop up on the test. Same goes for disaccharides, and these are two monosaccharides joined together. Sucrose, maltose, and lactose would be examples there. Then you have polysaccharides, and these are long chains of glucose units. Glycogen, fiber, and starch are examples there. So before exercise, drink 5 to 7 milliliters per kilogram, and that's at least 4 hours prior to exercise. If no urine is produced or if it's dark, you consume another 3 to 5 milliliters per kilogram 2 hours before. Not important to memorize these numbers whatsoever, by the way. Just going to read them off to you. You never know, something could pop up on the test. During exercise, you want to prevent a greater than 2% body weight reduction. That's where things can get a little bit dangerous. Monitor sweat rates to individualize intake, typically 4 to 6 ounces every 15 to 20 minutes. Fluid composition, drinks should include some sodium. You don't need to know these exact amounts. Potassium for rehydration. Magnesium would be the other one. Could potentially be in there. You do want some carbohydrates in there as well, 5 to 10% potentially. After exercise, consume 1.5 liters of fluid for every kilogram lost. Yeah, that one you probably should know actually. Consume 1.5 liters of fluid for every kilogram lost to ensure complete recovery. Rate limitation, avoid losing more than 2% of body weight. We already said that. Replacement metric, 16 to 24 ounces of fluid for every 1 pound lost during exercise. Yeah, that one's pretty good to know too. Look this one over a few times. Not worth memorizing much on here. If you listen to me say it a few times, you will know it well enough. So now we're moving on to the last section of this guide, and that is random stuff worth knowing. Let's get into it. Anyways, the nervous system has two main components, the somatic nervous system and the autonomous nervous system. The somatic nervous system is mostly under our control. It mostly involves skeletal muscle and things like that. The autonomous nervous system is automatic, as the name would imply, meaning it's not under our control. Anyways, the autonomous nervous system is split into two parts. The sympathetic nervous system, which controls our fight and flight response, and the parasympathetic nervous system, which has to do with resting and digesting. Type 1 muscle fibers are slow twitch, meaning they have better endurance but produce less power. Type 2 muscle fibers are fast twitch. They generate more power but have less endurance capabilities. It is supposed to say endurance, not deterrence right there. So again, type 2 muscle fibers are fast twitch. They have more power, strength capabilities. They're more explosive, but they fatigue faster. And type 1 muscle fibers, those are better for endurance, but they don't produce quite as much explosive force. When we're talking about scope of practice, the least aggressive answer will usually be the correct one. Example, you have an injured tennis player client. What should you do? Answer, you're going to show the client some stretches. You're not going to take him through a full-on bout of physical therapy rehab. You're just going to show him a few stretches that might help him out and leave it at that. Maybe refer out if needed. A few different types of stretching here. You have static stretching, and this is usually holding a stretch for roughly 30 seconds. And again, this is like the typical old school, just kind of chilling here, holding a stretch. Then you have dynamic stretching, and these are movement patterns designed to mimic the workout. Take, for example, doing a bunch of toe touches. So reaching up tall overhead, moving down towards my toes, coming right back up, doing those a handful of times before doing some deadlifts. Leg swings, arm circles. There's a million different examples here. Even bodyweight squats would count. Ballistic stretching is always the controversial one, and these are kind of bouncy and swinging around, and yeah, typically these ones are no good. So yeah, avoid ballistic stretches. They're kind of crazy. Next up, dynamic balance exercises, and these can be static or dynamic. And like you see on this balance beam right here, these involve transferring weight from one foot to the other. So you might be walking like kind of single file, like one foot after the other in kind of a weird balance-like motion. Of course, more examples would also exist there. Liability insurance. A personal trainer should carry liability insurance whether they're employed by someone else or self-employed. $2 million in coverage is recommended, and honestly, this is good advice. If something questionable comes up in a session, like your client sharing too much information about their divorce, the correct thing to do would be to redirect the focus of the conversation back to the workout. Good to keep that one in mind. ACSM, NASM, all these different organizations are always this way. And yeah, I guess for good reason. Goals need to be positive. Cueing also needs to be very positive, or at the very least not negative. So if you have multiple choice answers coming at you and something sounds pretty negative, it's probably not the correct answer. This is always a really good one to know, and you really never know when you're gonna need it. So remember breakfast, lunch, and dinner. You have 7 cervical vertebrae, and you can see those guys right here. So think 7 a.m. for these first 7 vertebrae. Again, these cervical ones are right up top. Next we have lunch, and of course lunch is at 12 o'clock, so we have 12 thoracic vertebrae. Again, these are the middle dudes right here. Then what time are you gonna eat dinner? Of course, 5 o'clock, duh. So we have 5 lumbar vertebrae right here at the bottom part of your spine. You also have 5 fused sacral vertebrae. That part's not quite as important to know, but hey, you can see those guys right down here. So in a sole proprietorship, a business is owned by an individual and there is no protection for the owner. An LLC, however, does provide protection and forms are required, but they are relatively simple compared to something like an S-Corp. S-Corp stands for small corporation. So an independent contractor is a self-employed person or entity contracted to perform work for or provide services to another entity as a non-employee. As a result, independent contractors must pay their own Social Security and Medicare taxes. A worker is an employee when the business has the right to direct and control the work performed by the worker. This includes hours worked, uniforms, etc. And if you're a typical employee in a gym or anywhere else, you're going to be a worker or an employee. Making a big old pivot over here to stroke volume, and stroke volume is the volume pumped out of the left ventricle of the heart. Cardiac output is another good thing to know, so heart rate times stroke volume equals cardiac output. So you have 3 parts of a plyometric exercise, and a plyometric exercise is like a jumping exercise. Anyways, part 1 is the eccentric phase, and you can see this guy, he's kind of lowering down into that squat, and essentially muscles are lengthening as he's going down there. Part 2 is the amortization phase, and this is the transition phase, or the delay between eccentric and the concentric phase. As you can see, he's almost ready to explode upwards. So it's that short but noticeable pause at the bottom. And then the third part is the concentric phase, and that is the shortening phase. Essentially, it's when the energy is released, and here I have an example of someone finally lifting off for the jump. The SAID principle is always a good one to know. The body will adapt to the specific demands placed on it. As far as the SAID principle goes, again, the body will adapt to specific demands placed on it. So if I'm doing a ton of bicep curls, my biceps are going to get really big and strong if I'm consistent and consuming protein, yada, yada, yada. Here's another thing that a lot of these organizations love. They love overtraining, which is an excessive frequency, volume, or intensity of training resulting in reduction of performance. This is also caused by a lack of proper rest and recovery. This is incredibly rare in our world as personal trainers, but hey, it's possible, it can happen. Even more extreme than that is rhabdomyolysis, also known as rhabdo, and that's the rapid breakdown of muscle resulting in high amounts of intramuscular proteins, and it can be dangerous to the kidneys. If someone works out way too hard for way too long, rhabdo is possible. Again, it is actually very rare. So you have 3 different types of levers, class 1, class 2, and class 3. None of this is worth memorizing, but hey, I'm going to say it anyways because you could get a question. For a class 1 lever, the fulcrum is in the middle, the effort and the load are on opposite sides. There are some examples over here. Again, not worth memorizing. In a class 2 lever, the fulcrum is all the way to one side, and then the load is in the middle, and the effort is on the opposite side. In a class 3 lever, the fulcrum is also all the way to one side, but the effort this time is in the middle, and the load is all the way to the opposite side. And again, there are some examples on this page, not really worth memorizing, probably worth looking over. So it's somewhat common to be asked about 2 different types of blood pressure meds. You have beta blockers and diuretics. Beta blockers lower your heart rate at rest and during exercise. A client's heart rate won't raise the same way during exercise when they're on a beta blocker, And again, that's actually why it's good for you to know about them. So diuretics increase the excretion of water from the body through the kidneys, and this could increase the likelihood of dehydration, and of course that is relevant to us. Also, some types of cold medicine contain a form of ephedrine that can increase blood pressure and possibly heart rate. Good to know this. For whatever reason, ACSM seems pretty into this one. Could pop up on the test. So there's two different types of diabetes. You have type 1 and type 2. In type 1, these people have to inject insulin. They are insulin dependent, and people usually develop this very early into life. Adolescence, teenage years, maybe early 20s, that's typically when someone's gonna know if they have type 1 diabetes. Then you have type 2 diabetes, and these people are insulin resistant. This one usually comes from poor lifestyle choices, and because of that, it's far more common. So if someone is eating way too much food, became overweight, they're not really working out all that much, again, type 2 diabetes is typically the one that we're looking at. So we have a few different types of feedback here. First up, terminal feedback, and this is feedback provided after an event or performance in order for the athlete to review and make adjustments prior to the next event or performance. Then you have intrinsic feedback, and intrinsic feedback is the physical feel of the movement as it's being performed. So maybe someone is shrugging their shoulders up super high every time they're doing a row, and I help my client to move their shoulders down a little bit. That could be viewed as intrinsic feedback. We have extrinsic feedback as well, and that's provided by external sources during or after a performance, and it includes things that the performer can hear or see. I feel like that one is fairly self-explanatory. Again, hear or see for extrinsic feedback, and touch for intrinsic feedback. You never know if one of these guys is going to pop up on the test, so good to go over them now. You have dyspnea, and that is difficult or labored breathing. You have syncope, which is fainting. Then you have orthopnea, I think I'm saying that right, and that is the sensation of breathlessness in the recumbent, essentially laying down position, relieved by sitting or standing. Moving on to sprains and strains. Strains would be a muscle strain, sprains would be a ligament. We have 3 grades for both, and price: protect, restrict activity, ice, compression, elevation. I'm going to repeat that back. Price: protect, restrict activity, ice, compression, elevation. Make sure you know what that is. This is what you want to be doing in either of these cases, and we want to follow that with some careful strengthening. So a grade 1 sprain or strain, we got a few ligaments or fibers torn. For strain, it's muscle fibers. For sprain, we're dealing with, obviously ligaments like we said. Grade 2, about half of the ligaments or fibers are torn. Grade 3, they're all torn, and surgery is fairly often required because, they're all torn. So really a loss of stability there, which is super unfortunate. We have global stabilizers and local stabilizers. In both cases, we are talking about core muscles. So global stabilizers are superficial, meaning they are outer compared to these deeper muscles. They manage larger movement ranges. They transfer loads between limbs. Some examples: the erector spinae muscles, the external obliques, the QL quadratus lumborum, the rectus abdominis, your six-pack muscle. We have the local stabilizers. These ones are deeper, so they're underneath the global stabilizers, and they provide more segmental stability. They are more endurance focused. They don't really move things around as much. They're more, again, like we said, stability. And they also give joint support regardless of movement direction. Internal obliques, multifidus, transverse abdominis, that's the one I always think of because that's that super deep core muscle where you're doing a plank or you're doing anything where you really have to stabilize. Just some examples there. Make sure you understand the differences between global and local stabilizers, and these are some good ones for you to know. And make sure you know some basic anatomy before taking this test. You don't have to be an expert, you just have to know the basics. Falling is the #1 claim made against fitness facilities and professionals. Another good one to know: falling is no good. Avoiding legal liability steps to success. So this is good to know. Definitely not worth memorizing the steps here, but the first step is screening. You want to screen people as you're kind of meeting them as they're coming into the facility. You want to test them next to see what they have going on. After that, you want to evaluate where they're at, see what they have going on. This is just the next step from this. You want to progress them over time. This is going to obviously increase their results. You're going to progress things carefully over time. And of course, you want to be supervising them. That is a big one. So these are how you are going to avoid liability. These are your steps to success. Worth looking these over once or twice for sure. Cardiac output is the volume of blood your heart pumps per minute, calculated by multiplying stroke volume, blood per beat, also worth knowing stroke volume, blood per heartbeat, by heart rate, beats per minute. Cardiac output equals stroke volume times heart rate. That keeps coming up in this video, and that's for good reason, because that could definitely pop up on the test. It almost certainly will in some form. So make sure you know what it is. So now we're talking about posture, and typically you're going to be observing posture from the front and the side, and you're going to want to do it static, where people are kind of just standing still. And then you're going to want people moving around a little bit too, just to kind of see how their posture changes as they're moving. ACSM is actually not that big on postural things, unlike NASM and some of the other organizations out there. Anyways, kyphosis is a good one to know. That one can always pop up on the exam. We'll talk more about that in a sec. Scoliosis as well, which is this sideways deviation of the spine. You should really kind of just have a general idea of what that is. We'll also break down an overly lordotic posture, because that one could also pop up on the test. Anyways, if the hip flexors and lumbar extensors are too tight and short, you could end up kind of with this overly lordotic posture right here. We're all supposed to have a curve in our low back here that goes inwards, but this person's curve is a little too big, and that can have some negative consequences. Don't memorize all this stuff, but it's good to just have a general idea of what's going on here. So a kyphotic posture is this overly rounded forward posture, and again, you can see that right here. So basically what's happening there is the interior chest and shoulder muscles, lats, and neck extensors are too tight and shortened. And again, this one makes sense. If everything on this front side here is too tight and shortened, I'm going to be kind of just like stuck in this position like this. Again, that's what someone with kyphosis has going on. These guys right here on the front side, too tight, too shortened. So if we already said that these muscles on the front side are too tight and shortened, these muscles back here that are on the opposite side of the body, they're going to be overly lengthened, stretched, and weak, and that should make sense based on some of the stuff that we talked about earlier in this video. So when it comes to posture, we also have to think about what's happening with the knees. We have a normal knee alignment here where it's a pretty straight line down. Knee varus, where the knees kind of bow outwards if someone is just standing there. Typically, you're going to see it more if someone is doing a squat or something along those lines. And then you have knee valgus, which is where those knees kind of cave inwards. Really obvious to see when someone is squatting, whether they have issues with knee valgus. So good to have an idea of what each of these things are. Normal is over here. Knee varus too far out to the sides. Even more common than that is knee valgus, and knee valgus is definitely an issue if it's happening when someone is squatting. So there are 3 stages of the general adaptation syndrome. Stage 1 is the alarm reaction, and this is your initial reaction to a stressor. Think the fight or flight response. Stage 2 is resistance development, and this is when your body increases its functional capacity to adapt to the stressor. And then stage 3 is exhaustion. If the stressor is intolerable and continuous, eventually this will lead to breakdown and injury. So when it comes to exercises, there are open kinetic chain exercises and closed kinetic chain exercises. For open kinetic chain exercises, the distal part of the body moves. So some examples would be curls, leg extensions, or bench press. If we're looking at the leg extension, the distal part of the body or the knee and ankle are moving. In a closed kinetic chain exercise, the distal part of the body is stationary, so if I'm squatting, for example, my feet are planted to the ground. Same thing is true for a push-up or a hip bridge. Exercises on the floor where you're laying on your back or supine are contraindicated for pregnant people after the first trimester and for people with hypertension or high blood pressure. And since we have a person doing a bridge down here, a common mistake that people make while bridging is raising their hips too high, which can cause hyperextension in the lower back, Keep all of that in mind. I've seen questions asked about that in particular. So guys, keep in mind, this video is only one part of the puzzle that is studying for your ACSM EP exam. You shouldn't only be using this video to pass the big test. You should, at the very least, skim through the textbook, link in the video description down below for that. Also, I'd highly recommend using Pocket Prep, which I have a link for down below. Sometimes my link will grant you a discount if you use it. Anyways, Pocket Prep is just a great way to review everything before the big test. The 1 and 3 month options should be considered. You should consider purchasing a practice exam. Obviously, I'm biased, but I think ours is a better value than ACSM since I personally break down for you why some answers are right and others are wrong. Also, make sure to watch each of these 3 basic anatomy videos once or twice leading up to your test. Don't bother memorizing everything in these videos, but knowing basic bone and muscle anatomy is pretty big for this test. Watch this part 1 and the upcoming part 2 video, which should be out in a week or two a few times each. Make sure you understand everything that I go over in these 2 videos at least fairly well. Good luck to all of you, not that you're actually gonna need it. Study hard, do an hour or 2 of work most days of the week, and within 2 to 6 months, you should be good to go. I know that 2 to 6 months is a decent amount of time, but in the grand scheme of your entire life, that's not that crazy of a commitment. This is the start of your new career. If any of you have any questions or comments about anything that we went over today, or just passing your test in general, make sure to leave those down below. I will respond to you. If you appreciate the hard work and tons of hours that went into making this video and guide, please don't forget to like the video and subscribe to the channel if you haven't done so already. That support really does help us out, and it allows me to keep making free trainer education content for all of you. Thanks for watching, everyone, and until next time, stay sorta healthy.